Morning, everybody. Lovely to see you all back, ready for action. And what an action-packed day we do have. Who was here yesterday? Nearly everybody? What'd you think? Great? Yeah, it was good, wasn't it? Yeah, really, really interesting, a little bit of fun, and lots of hope, I think. Hope and potential. So fantastic. Now, the people who weren't here, where are you? Okay, all right, welcome to day two. I'm Kathy Balding, I'm the facilitator, and also welcome to the people on the web as well joining us today. So just before we get going, if you did drive, there are parking cards to get out of jail free cards, Brendan Murphy used to call them, scattered about your tables. And the Wi-Fi is conf, C-O-N-F 2019A, all lowercase, and it seems to be working pretty well for those of us who have availed ourselves. A couple of things from yesterday. People are asking about getting the slides. Well, of course, as we said, the slides are all in the webinar, which will be available. If you wanted a particular presentation, contact Marie Roberts and her team. And they will see what they can do for you there. And also Catherine Todd's booklet on the flu. If you wanted to provide feedback on that, please feel free to do that via Marie and her team as well. It's my great pleasure today to be presiding over an amazing range of speakers. I think it's a fantastic program. And also I wanted to thank all of you, all the participants from yesterday, for being so punctual. I did just want to make the point again that time is of the essence and we want to get you away absolutely on time. So if everyone plays their part, speakers and participants, we will definitely do that. But I do thank you for that yesterday. It was absolutely fantastic. Today our forum is being held on the lands of the Wurundjeri Willem people, and I wish to acknowledge them as traditional owners. I also pay my respects to their elders past and present and Aboriginal elders of other communities who may be here today. And before I introduce Anthony, I just wanted to mention the evaluation for the past couple of days that'll be sent out on the SurveyMonkey tomorrow, I believe. Deb, is that right? SurveyMonkey tomorrow, the evaluation? Putting her right on the spot as she walks in the door? Yes, yes. All right, so obviously, it's very, very important that you give us feedback so that we can make it even bigger and even better next time. So it's my great pleasure now to introduce Anthony Carline from Ambulance Victoria, who has over 20 years experience in Australian ambulance services and is a current member of the Ambulance Victoria Executive and Operational Exec teams. Anthony has responsibility for the strategic delivery of statewide call taking and dispatch, referral services and contracted nurse on-call services. He's a part of delivering Ambulance Victoria's strategic plan as part of the Ambulance Victoria Best Care Framework, and I'm going to take the privilege of being a facilitator today to note that those of you who saw my presentation yesterday and you saw me talking about strategic quality system and defining high quality care, that's the best care model that AV is implementing. And they are implementing it, may I say, absolutely brilliantly. So I'm excited for anything that Anthony might touch on today as part of the great work that they are doing. So please welcome Anthony Carline.
Thanks very much, and I'd also acknowledge the traditional owners of the lands and pay my deepest and heartfelt respects to their elders past and present. Thanks for that lovely introduction, and thanks to everybody for being here today. This is a little bit like a paramedic room. Like, you can guarantee a room of paramedics, the front row will be empty. And then the extrovert will march down the front and sit down there. But look, again, thanks very much for giving me the opportunity to speak today. I think this is an opportunity, I think, to, I guess, show what Ambulance Victoria's part or broadening part in the health system is, and where our contribution is, and some of the things that people don't often well understand. You know, it was less than 10 years ago we were load and go. You call, we haul. Pick up the phone, call 000, an ambulance came there and took you off to hospital. We didn't do a great deal. You know, I think we all realise now that the health system and our contribution and the way we work together, that has to change. Yeah, that has to change, or we just won't meet the demands in the future. So, look, we could have taken the normal approach here today and come and talked about our SOP and, you know, the fact that when the system's under demand, essentially we don't meet the targets the government set for us. But, you know, it makes sense to take a different approach, because ultimately at the end of the picture for ambulance, there's a patient, you know, so our availability directly correlates to the outcomes of our patients. So I just want to talk about the patient view and a couple of case examples that occurred on the 14th of Feb 2019. So ambulance caseload on this particular day was significant, and our caseload ranges from, you know, 800 cases a day when things get really rough, up to 1,100 cases a day when we're busy. The eastern suburbs in particular, which is basically, you know, sort of from Bayside all the way down to the peninsula, every single health service was clearly under significant pressure. There were numerous two-hour waits for ambulances in the emergency departments. In some cases, many to 4 hours. 5 MICA teams that service, so our intensive care units that service the eastern suburbs, 5 of them were at a hospital for greater than 2 hours at the one time. And at one stage, we had no intensive care ambulances across the whole of Melbourne. Basically our fleet, now we have, you know, we range from about 200 up to about 240 ambulances a day, depending on the time of day running around. At this point in time, we had about 40 that were over shift finish time, so they were ready to go home. And our fleet availability was less than 10%. So if you just think about how big and the sprawling what Melbourne looks like, that gets a little bit scary. You know, so as a consequence of that, we decided to enact the emergency response plan. So on that basis, that's essentially when the department become involved, all our managers stand up, we start coordinating centrally from the Emergency Operations Centre. I'm up when I don't want to be up, but I get up because that's what I do. So 2 particular case studies here. You know, one of them is about a 42-year-old patient with anaphylaxis and a 64-year-old with cardiogenic shock. These were in adjacent suburbs, and they're about 10 to 15 minutes from the closest hospital. They were dispatched simultaneously. So if you think back to where those MICA resources were sitting at that point in time, we had 2 based at the point of call, very time critical patients that required intensive care support. So the first patient, 32-year-old, no past history of anaphylaxis, antibiotics, reaction, rash, hypertensive, altered conscious state, short of breath, hypoxic. You can see the vital signs up there. So this patient's immensely hypotensive. They have a Glasgow Coma scale of 13 initially, decreasing to 3. So this patient's you know, heading in a bad way very, very quickly. So our ALS paramedics, who were the only advanced life support paramedics, were the only people available, and essentially they give IM adrenaline, given on numerous occasions, oxygen, by face mask, fluids, and then they transport quickly if it gets to the point where they don't have intensive care and they can't stabilise that patient. Immensely difficult extrication to paramedics trying to get a very, very sick patient out of their residence to the ambulance to get to hospital. And I think if you start to look at the timelines, just the extrication took 22 minutes, no one there to support, time to get to hospital, 15 minutes, 20 minutes on scene. So all of a sudden we've got a patient that's time critical that we can't stabilise, and we've been with them for greater than an hour. Would MICA have made any difference to the intensive care ambulance? I guess that's the question, but they certainly would have administered intravenous adrenaline. They certainly would have filled the patient, so got their blood pressure back up, and they would have intubated the patient, particularly sedated the patient. So the outcome for this patient, 8 days in ICU, being managed intensively, multiple issues as a consequence, 13 days then on a ward before being discharged home. When we debriefed and we spoke about this patient, we sort of said, well, is this best care? It's not best care, because our clinical response model is based on tiered support, you know, and if you think from helicopters to doctors to advanced life to support to basic life support, if you think about that continuum of care, this patient needed what more than we were able to deliver them on that day. And just another case, this was the other case that was in the adjacent suburb. Again, we had no intensive care, pretty significant history you can see up there. You know, lots of comorbidities going on, but still relatively young. The older I get, the more that changes. You know, so been sick for a couple of days. Again, if you look at the signs and symptoms and the vital signs there, this patient was full up. You know, so they're sick, very, 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 very sick. We carried out ALS practice again. If you look 24 minutes, 12 minutes transport, the 20, 30, 40 minutes they spent on seeing. Blood pressure got worse. They had a polymorphic ventricular tachycardic arrest. On arrival at the hospital, they were resuscitated and they died at the ED. Now again, would MICA have made any difference? More than likely, but you don't ever really know. But again, we would go back to that patient never got the best care that we could provide them on that day. So we didn't give them every opportunity. People obviously die, but ultimately we want to be able to walk away and say we gave it the best chance that we could. So they're the patient stories, and they're again, as I said, we could have talked about, you know, the fact that we're in the papers every week about hitting 84% rather than 85%, but ultimately what we're really trying to sort of, I guess, paint the picture of here is that, you know, to deliver best care, that takes, you know, it takes a system. We've got, you know, an integrated approach that we take in ambulance itself, but equally we need to work with health services and partners across the board to deliver best care. And there's a few examples that'll paint that picture a little bit further shortly. So this is just a representation, I guess, of the amount of hours that we lose at emergency departments every single month. Now, just the picture, so just in the blue there, the total amount of hours. So if we just look at the Feb 19, 733 hours, and what that is representative of that period above the KPI. So the KPI, just for reference, is it's 90% of patients within 15 minutes. And I see a couple of people that I've sat across the room for over many years nodding their head like that or going like that. But that's the amount. So the KPI is immensely liberal. You know, that's to be perfectly honest, it's not a stretch target by any means. You know, this doesn't count the time where the paramedics are sitting there doing their paperwork. You know, that's how much time beyond the KPI, you know, and if I just break that down to ambulances, so if we sort of think in the space of a 10-hour shift, for example, it's a lot of ambulances, you know, and we augment the system by about, I talked about that 240, 280 ambulances. We probably augment it by about 20 ambulances every single day above the baseline to try and account for this sort of challenge. So we're over to referral service. This is the uplifting bit that everybody will go, yes. You know, it's, so our referral service has been a pretty amazing journey. I never want to say that word, but I will, journey. You know, when we started this in 2003, we were just the Metropolitan Ambulance Service before we had a big merge in 2012. And the KPI was between 5 and 10 patients per day referred to alternative service provision. It was at the time evolutionary or revolutionary. It wasn't being done anywhere else. You know, and today my team sees or assess about 700 patients a day across Melbourne. Basically, what they have at their disposal is they can dispatch ambulances. So when they go through the system after a secondary triage assessment by either a nurse or a paramedic, they can dispatch ambulances. That happens sometimes. They refer to alternative service provision. They can provide phone advice. And then they do an increasing amount of care planning and patient management. That's just basically a very basic representation of how the 000 system works. You know, people have probably experienced essentially Telstra answer the phone, and they ask you which service you require. They then send you off to the state and the service that you require before you go through a primary triage by the Emergency Services Telecommunications Authority. They're a legislative body that provide primary dispatch only. So if you think in that case, people that are just very, very obviously sick based on algorithms, we have governance of that system. They can then obviously go into referral service, they can get a non-emergency ambulance, they can go to a number of alternative care services provisions or providers. So they're just some of the pathways that we currently have. We provide lots of care advice, that's a pretty significant portion. We can direct them to nursing services, so we can actually send them to nursing services. We can take them through our own mental health practitioners and nurses, and that's a growth industry. I'm sure you're all aware of that, and it's been immensely successful. So they probably, and anyone that, not sure if anyone works in mental health, but everybody tends to see these patients, but 50, 60 patients every single week that don't end up going to an emergency department as a result of our mental health nurses. Now 50, 60, that's a pretty substantial, when we look at the premium on mental health beds, that's pretty significant. We think we could do enormously better in that space with better partnering. So being able to speak to mental health clinicians at health services, we think we could double that conceivably. We also do a lot of referral to super clinics, telehealth, so My Emergency Doctor, significantly increasing, particularly Wangaratta's a massive highlight in that space in rural Victoria. We'll just move to that wasn't me, was that you, Cameron? No, I don't want to at you. Sorry, so in reach programs, this is just really about, this is probably the main example of sort of best care and partnering and where we need to go. These are the current in-reach programs. We probably refer to them as outreach, I'm not sure, but they're reach. And this is where we go. You can see increasingly some access in rural Victoria. We really need in-reach to be registered as part of the National Health Service Directory. The more options we have available, the more chances we have of making sure our patients get the best care available at the time. So for context, conservatively, 20 to 30% of patients that we take to an emergency department should go somewhere else. There should be somewhere else for them to be seen. Should be somewhere else for them to get the care and get connected to what they need. But the reality is we're no different to an emergency department at points in time. If there is no solution or that solution's not timely, we have to do what we can for the patient and we take them off to hospital. Large portions of those patients might get Panadol and a script and get sent home. They may only be assessed and not be seen at all. And those are the examples that that's the 30%. That's where we'll be successful, when we can do something with that 30% of patients. We want to, and I'm sure this has come up, the ability to share data and work together and share information. It's really important. We're nowhere near as connected as we would like to be. We should have access to what happened to that patient, what happened the last time that patient was taken to the hospital. We should have their medications. There's an awful lot of work to do in the data sharing space, so that when we go through our triage systems, we actually know what the best pathway is at that point in time. And a growth business for us, reality is advanced patient care directive plans. We need to be better linked in and understand patients' needs and what their directives are at end of life, so that we can, again, not take people off to hospital unnecessarily. That's just a distribution chart of where we send people. A question that comes up all the time, particularly when we're under a bit of pressure and we're sitting across the room at a health service, is we just tell people to come to the ED by themselves. It's not true. That's not what the data says. About 7.5% of the total cohort of patients that undertake referral are referred to go to an ED. Whether they all go there or not, we wouldn't necessarily know, but they'll be provided that advice. And you can see the numbers there. Telehealth is pretty significant. If you look at the period 1st of the 3rd 18 to 28th of the 2nd 19, 11,000 patients plus to telehealth. The 12,000 unsuitable comes up quite often. That's just essentially the example of this, and this probably shows you the system in general. Somebody's driving past a park, sees someone laying on a bench in the park, calls 000 and just keeps going. So these are the ones when we attempt callbacks, etc. We just won't make connection for them for whatever reason. Self-care, lots of self-care. Care plans. Care plans is becoming a significant business for us. So generally care plans are people that call multiple times. And when you see some of these things, you've got to chuckle, but they're not really that funny. The person that calls at breakfast time every morning because their brother's late to come and give them their eggs. They need somebody. We're there, but we could be doing something better with our time, to be truthful. Just a little bit more on the frequent caller management. This has been a massive bit of growth for us. You can see on the right-hand side, 2017, 2081 calls relative to care plans. So they're people that we have recorded in the system. And on the other side, you can see 3,552 in 2018. So it's growth industry. It's pretty significant. We are a logical connecting point for the community. But I guess the message is we're not necessarily looking for work, if that makes sense. We're not, yeah. So we certainly see this as a pretty significant contributor to best care, because this ultimately allows our practitioners to go back and speak to a GP, to update the referral care plans. And you can see we're relatively well connected, but we will have, and I should have put another map, but I could show you a heat map which shows great success, and then heat maps that show you not much success. And much of the things I'm sure you've talked about yesterday and I'll talk about today is some of the disadvantages, areas and access that people have depending on where they live. There's best care again. I reckon I've got it in 6 times. Have we been Michael? 6 times? Yeah, it's just like ding, ding. So these are really just where some of the very obvious things that we would like to do better and where the opportunities we see. Mental health for us, we would be able to do that. So if our mental health clinicians are seeing 120 patients a day or assessing 100 a day, they'll refer 60 to an alternative service provider. 60 are likely to still get a transport. But most importantly, what they're going to get is a quality assessment before that decision is made. If we had better access into the health services relative to mental health, and have better understanding of history, and we're able to speak to physicians, etc., I mean, that might be 80 or 90 cases, which is a pretty significant win for the system. We need to develop systems that have hospital at risk of representation. So some of these things happen in the health services quite well. We don't have fantastic systems to do that. One of the real areas for us looking at the moment really closely is, falls without injury, falls with injury, and in particular, really targeting the falls without injury, because that's obviously a precursor to comorbidity, and you're not going to have a great life if you start falling at home. But the earlier we intervene in those spaces, the better. Better sharing again around, we talked about palliative care before. I'll show, I think I've got a screen coming up, but overwhelmingly, the largest cohort of patients for us is now over 79 years old that calls and referral assess. And I heard something the other day that anyone born after 1981, has got a life expectancy of 132 years. So is anyone born after 81 here? You're going to be busy, really busy. Yeah. Yeah. So again, data sharing, and I think this is an interesting statistic. So 11 callers over 3 months received 254 ambulances. So these are gaps in the system. So these are people that can be homeless but clearly have dependency issues. But from a resourcing perspective, that's not sustainable. That's not sustainable at all. And we're doing some very interesting thing at the moment. No accountants in the room? None that'll put their hand up. But we've been doing some interesting things around billing, and this comes back to best care. I had a very interesting discussion with one of our accountants recently who came to me and said there was a patient that had 9 bills totaling $47,000 or something along those lines. And we started sort of talking about where the opportunity might be there. Because clearly this person doesn't have that amount of money and there's something more going on, and we need to find out where that person needs to be connected in the health system. That's an accountant's version of best care. So that's their part. When you sit there and go, well, where do I fit? And it's our mantra in Ambulance Victoria is, if you're not contributing to best care, you have to go and do something else. So everybody that sits in the system, whether you're a clinician or an accountant, has a role within best care. One of the pieces of work around technology in particular, we really want to get to the system that our patient care records are actually sitting in the emergency department before we get there. We're doing a lot of work in we call it the connected paramedic space, but this is about making sure our data systems link up as much as possible. And again, this just comes to timely care and sharing of information. If clinicians in the emergency department know what's coming before it comes there and they've got a body of evidence before they get there, we'll just be able to treat them a lot better. And equally, that comes back the other way. Like really final disposition. Did what we go to or did what we assess, was that what happened at the end? It makes a difference. And partnering. I think I'm near the end, but partnering is just crucial. I think everybody knows, and that's why everybody's here in the room. We are just not going to meet demand into the future. 1.8 million more Victorians here. City just going out like that. I don't think they're building any hospitals. They're putting some roofs or another floor on a few of them. We know that's not going to meet capacity. So I'll go back to that 30%. That's where the opportunity cost is. That's where we have the opportunity to make a difference. There we go. So look, I guess that's my bit. We're part of the system. We want to work together with people in the future. We think there's massive opportunity. I think we all know there's fat. There's fat in the system. We can do things better. But that's our part in the puzzle. Thanks.
Thank you very much, Anthony, for mentioning best care 15 times. That was excellent. But and quite sincerely, I'm very appreciative of you also pointing out that everyone in the system has a role, and that's something that AV is doing particularly well with that model. And we talked about that a little bit yesterday. Questions, comments? There's obviously this is pretty critical to what we're talking about, and in the interface and the connection, and where timely care fits in that. So I've got one there and one there to start. And if you could just say who you are and where you're from, that would be great. Thank you.
Hi, my name is Adele. I'm from DHHS and I sit within the ambulance unit. Nice to meet you. I just wanted to ask, a VAGO report came out recently talking about that, and this is specifically to do with mental health, that Victoria was lagging behind other states. And I just wanted to find out what engagement ambulance were having in relation to what that report looked like and the recommendations.
Yeah, so we've certainly take every opportunity we can, I guess, to share our own experiences and the impact on our system, on the system. Conservatively, it's 30% of our work in some way, and the very obvious part of it is the bit you see on the TV, somebody jumping in front of cars and doing crazy things, but so many of our patients that have other comorbidities actually have mental health challenges as well. And for us, we're in a very interesting space, and it's so we sedate and restrain. We still do plenty of sedate and restrain. you know, we can't at this right at this point in time see where we will make that shift. We know that it absolutely has to be, you know, there has to be, humanity needs to be applied to this in all circumstances. But from our perspective, you've got paramedics sitting in the back of an ambulance with a patient that from the point you first see them to the point you drop them off in hospital, things change, you know. So we're focused on training. We want our people to be better. This is not, and you'll see it, for example, there's discussions around mental health ambulances and PACER teams and, you know, your CAT clinicians and all of that. You know, everybody has more work than they can do in the space at this point in time. But when you look at those, that 30% of numbers, is the reality for us is it has to be core business. You know, it has to be core business. To be able to manage those people, particularly in the acute setting. But I go back to that partnering and outreach, Adele, is we have to start working closer with health services and mental health clinicians to get to the right outcome, because ultimately we need to reduce the amount or the volume of our patients that need ambulance because of an acute episode. So it's pretty challenging.
Hi, Marie Roberts.
Hey, Marie.
Hi, Anthony. That was terrific, that discussion. Just a little bit more about the InReach/Outreach programs.
Yeah.
I'm assuming you partner with community-based services as well, and just be good to get a sense of the breadth of that, I guess. How successfully you've been able to do that?
Marie, we've had some, so we've run some good programs down at Gippsland recently, where we piloted things called patient boards, where essentially our referral clinicians would have access to the same information that the clinicians within the regions had. It wasn't hugely successful, to be honest. PHNs, there's an obvious opportunity for us in relation to PHNs, and where I've actually just recruited a director that sits in that space for triage services. We're nowhere near where we need to be in the PHN space, to be honest. We now have some strong relationships at an executive level, and we're building relationships at the operational level to see where the opportunities and leverage might sit. We're not, so we're like most organisations. You should only do something if you can do it better and more effectively than somebody else. So the opportunity for us is around, you know, both formal and informal partnering, contracted services, but the connection, just connecting better, seeing what they see, seeing what we see. We just think we'll end up in a far better place. But it is absolutely a clear focus of us in relation to patient pathways. PHNs are probably the best opportunity we have right now.
I'm Andrew. I'm Director of ED at St Vincent's.
Hey, Andrew.
Your fourth dot point on your key themes interested me enormously, as the ED directors and departments have significant challenges with the frequent callers, particularly in relation to drug-seeking behaviour. I understand that your care plans are linked to residential addresses,
Yep.
and that's one of your big challenges, because when they're not coming from their residential address, therefore the plan isn't connected.
Correct.
We sort of have an informal way of communicating about recurrent, frequent attenders who, you know, jump between one hospital and another, because we don't want to. You guys don't want to keep giving them opiates, and we don't keep wanting to do investigations that they've had down the road, you know, earlier in the week. So, from an ED director's point of view, we'd be really interested in getting involved in that discussion about how do we better coordinate plans for these patients.
Yeah, Andrew, there's a massive opportunity there. One of our limitations is the computer-aided dispatch system, and I see some nodding in the room, but essentially the technology that provides information on what we go to and when we go to and collects it, it's not what it needs to be. So our ability to information share is pretty much limited to the VACA system. You know, our EPCR or patient care record, we don't necessarily have a system, for example, where, and we're doing a lot of work in this space around where, you know, conceivably what you should have at a minimum is when that patient's details, whatever that might look like, get to, it should bring up the previous PCR and where you took them and what you gave them. And, we won't necessarily get someone on the second presentation, but we should get them on the fourth and fifth presentation. So our ability in our systems, ability to have all of the patient care information at hand is not where it needs to be. But I think we've got a massive opportunity. We've done some really good work, I think, with St Vincent's, particularly in that Salvo space around a lot of the sort of homelessness in the CBD. So there is massive opportunities, and I think that's something we can put very high on our agenda through our liaison frameworks, Andrew.
I have a question.
Yes.
Best care starts at point of care. How do you get across to your on-the-ground paramedics the importance of the interface with the ED and how critical that is in both patient care and also relationships with the hospitals?
Yep. So the word we're using now is point of call. So that's for us is where does treatment start? And for us a lot, and I certainly think in whether it's a clinical or a standard leadership sort of position, is everybody in your organisation needs to be on the same page. It's absolutely critical, and we do a lot of that sense making by saying to people, the accountant example, here's an example of somebody that doesn't wear a uniform providing best care. We educate, so it's part of our continuing professional development. We continue to revisit it all the time. All of our infrastructure is based on best care. So our strategic framework follows the principles of best care. When we undertake a multidiscipline approach to looking at a case investigation, we use best care. So we've made it the language of the organisation. I'm not going to suggest that every single paramedic you would go to would necessarily be able to tell you safe, effective, connected care and where that sits, but they'll increasingly be able to tell you where their piece is in the puzzle. And the example of that is, workforce planning is a big part of best care. If you're not structured up to deliver best care, you can't deliver best care. So what we're really doing is our language. So we've established, I'm sure some of the same is we have, so I have an operational best care committee that has representation from Nurse on Call, the Emergency Services Telecommunication Authority has a medical director on it. It has staff representation that makes sure it picks up the gamut of where my people work, from Ballarat out to Burwood. And what we do is we use it as the point of the discussion. So if somebody's going to, the very clear example is if you're going to write a paper on something, it should follow the methodology of best care, because it is a methodology. It's a methodology that allows you to step through a problem. So we've certainly, I can say we've certainly embraced it. We're not, I don't know where we are on the maturity curve. You might know better than we are, but we're well and truly on the way.
Any other comments, questions? Yes, we have one over there, one over there. Oh, yes, we have three. Okay, and fortunately we have time. You'll be signing on.
Do you want me to do mine first?
Keep up.
Okay.
Keep this up.
My question is really about, I guess, it's a changing landscape for Ambulance Victoria, and you talked about mental health nurses as part of your team. Traditionally, you've just employed paramedics. So I'm interested in just, the training challenge for paramedics in moving into this new space, which is not treating and transporting everyone, and what your engagement with nursing workforce is as well.
Yeah, so I guess coming back to workforce planning, I'm just in the process of recruiting 7 team leaders that sit across the referral service, and they'll be a combination of nurses and paramedics. I think this comes down to diversity. Let's get out of our comfort zone and our lane and say that, a range of different experiences and capabilities will ultimately deliver the outcome. So we do have challenges. Paramedics come from a world that is very protocol driven historically. Now we're far less protocol driven than most ambulance services, but there's a risk aversion. So we're always balancing the risk aversion of telephone triage and the perception of it, to be frank, more than anything, because the data is very clear. Telephone triage is not the most risky thing we do. Far more risky things happen when we get there. to be frank. So I think for us, it's about having diversity in the system, Marie. Our medical directors, our clinical leads, our paramedics, our nurses, and saying, well, it takes a village, to actually deliver the best outcome. But we continue to revisit where training changes all the time. The biggest challenge in the space is the speed of change for our practitioners. Through the governance system, the protocols or the guidelines, we call them, they can change 3 or 4 or 5 times a year. And it's a big book and it's getting bigger. You used to keep it in one piece of paper in your pocket and you were good to go, but it's a very, very, very thick book now. So we were very much, the message we do have for our practitioners is they're clinicians. So we're a registered profession now. I'm sure everyone is aware of that, or most would be aware of that. So these are clinicians. They're no longer load and go. These are professional clinicians. So yeah, diversity I think is the key.
Hi, I'm Belinda from Alfred Health, and I work in the emergency department. Thank you for your presentation. I found it really informative. I'm just wondering, in terms of communication on a day like the 14th of February example that you used, where you go into escalation,
Yep.
How is that communicated to the individual emergency departments? I quite often find that we get informed when we already have 10 or 15 ambulances waiting,
Yep.
and we kind of don't really get the backstory that you are in escalation. I'm just wondering then, from our point of view, if we were to know that, or if we got some earlier communication of that, what we could do on our end.
Yeah, it's a good point. And distribution in general is a very topical subject. The challenge in that system. So our viewpoint is, as much as practical, we want the system to do its work in relation to where patients go. The ideal outcome is that a patient actually goes to the place where they have their history. Barring not having a relevant history, they should go to the closest health service. That's barring acuity and specialisation, that's the system that should work. So clinicians obviously make that decision at the time. It's not something we can automate because we can't possibly know all of the information to make the decision. The challenge with it quite often is it happens very, very quickly and it changes very quickly. So the example is, and I've looked closely at that day, is we start distributing and we say to 5 ambulances, don't go to the Alfred. We would like you to go 3 to go to St Vincent's and 2 to go to Western Health or the Melbourne or something like that. Before they're there, it changes. So the situation changes. You'll then get, coming out of the West, you'll get a dozen cases that come out. We've obviously got the arrivals board, but we appreciate that's not perfect at this stage. Generally what we default to in the system, and it's good feedback and I will take it back, is we default to the relevant area manager who's got responsibility for the hospital to pick up the one-on-one discussions, because our resource managers are focused squarely on making sure ambulances are getting to patients once the pending box. We've got a pending box and the number starts to go up. We want to do it better. There's no doubt we want to do it better. We've made a fair bit of progress in the last couple of years. Arrivals board, years ago we had nothing like that. But it's a challenge because it happens really quickly. But I think the liaison framework for us is let's make sure the rules of engagement around that are what they need to be. Challenge.
Do we have one more? Yes, we have time for one more, depending on how long or short your question and your answer is. So we got a couple of minutes. So.
Is it a yes/no question?
Yeah. Yes.
I don't know.
Please limit your questions to yes/no.
My name's Pat Stan and I work for the department in the Rural and Regional Health branch. And I'm just wondering what your thoughts are around the workforce, particularly in the rural regions, with the increasing expansion of AVs, on the road and, workforce. rural and regional overall workforce is dwindling, and have you got any plans of how to manage and recruit into your rural workforce?
Yeah, it's really challenging, isn't it? The point when people commence their career is the point where they arguably need the most support, isn't it? And most exposure as part of their development. So how do you, so the reality, you have a vacancy in Yakandanda. You know, should you be sending a 23-year-old paramedic out to Yakandanda? You've got to have the right systems, clinical support systems in place to be able to support people through that. It is challenging, and we have two economies at the moment, you know, moving to professionalism and universities, etc. We have a large cohort of paramedics that sit sub 30, less than 30 years old, and then we have a lot of our practitioners out in the rural regions are at towards the end of their careers. Look, we have a lot of systems. So we have an RSDP program, for example, whereas what we do is we support local volunteers or our first responders to enter into the university system, because we know that if you start in a town, you're from a town, you're invested in that town, you're more likely to want to stay in that town. For us, we're doing a lot of work in developing, you know, what does simulation training look like in the future? You know, what does the support network look like to ensure that as junior paramedics come in, they can go out there? I've got a personal view, you know, I've been all over the place as a paramedic, and you know, I was a regional director in Hume before I was a regional director in Melbourne before I moved into this job. And to me, it makes the best clinician. It's the best experience you can have to have experienced both the metropolitan and the rural system. They are very different. They teach you different things. And I think there's a time in your career to do both. So we do have a lot of programs around encouraging people to go out there. We try and get the balance right between senior and more junior clinicians. We don't incentivise it, for example, by, you know, you get free coffee down the road, you know, but we don't incentivise in that way, but we do have programs to encourage people to move into particularly some of the more challenging towns, and you will see them in the paper from town to town. From time to time, there are locations where it's difficult for us to recruit to, but we're really actively involved in it and trying to do it better and better.
All right. Short question.
Very short.
Short answer.
Hi, Anthony. I'm Shelley Castro-Crowd. I'm the Chief Operating Officer from Austin. Firstly, I really enjoyed your talk. I thought it was fabulous to see that presentation. And also want to commend Ambulance Victoria on the work. They've been doing really proactive work, which I think is incredibly exciting and really grand. One of our values at Austin is together we achieve, and I think that's absolutely what we're talking about here, about working as a system. So just wanted to ask you, what's the key message that you'd like us to take back to health services to help to support Ambulance Victoria?
Well, let's sit down and actually talk about the problems. So you'll have a monthly liaison meeting every month. So what do we actually talk about when we go to those meetings? What are the actual problems? What are the drivers, and where are the opportunities? You know, there's that sort of almost rote learning KPI discussion around, well, you didn't do it again this month. You know, where are the actual opportunities? So let's talk about the opportunities. And I spoke about a couple of examples there about in-reach and access. Mental health would be a good start, you know, so having mental health as part of your liaison framework, I think would be a very, very good start. You know, they're not a building just down the corridor, or in the Austin's case, up the road. You know, they're not. They're part of the system. Having them joined up and having that joined up discussion, I think would be a pretty good start.
All right. I think we could go on, but we have to stop, unfortunately. So thank you so much, Anthony.
Thank you.
Thanks very much, Anthony. How interesting. Picked up on so many themes from yesterday, and he wasn't even here yesterday, which says to me that we're all talking about the same things. We just might not be using the same language. So that importance of getting on the same page, that importance of finding a common definition of success, some common goals for the quality of care we're trying to achieve, and getting some common language to work together on them. From me, who doesn't have much to do with this particular part of aspect of the sector, is a really strong message coming through. So, and I'm very glad that Catherine's self-serving here. Well done. I know.
You want something done to yourself.
Go for your life, Catherine, absolutely, while I introduce you. Dr. Catherine C is a respiratory physician and the Director of Respiratory Medicine at Northern Health, who has a special interest in lung cancer management. She's also chair of the Northern Lung Tumour Stream. Catherine's passionate about the synergy between clinical and operational excellence. I think that's a bit of a common theme too across the couple of days, and works to develop hospital services and systems that support the two. And Catherine's going to talk about to get a patient in, you've got to get a patient out, which sounds like it makes quite a lot of sense. Please welcome Catherine.
Thank you. So I have to confess, I'm actually talking a bit about work that that's not mine. So I'm presenting on behalf of Northern Health, not behalf of Catherine C. In terms of what I'm going to cover today, I'm going to talk a bit about what Northern Health looks like currently, because we're rapidly growing and changing. Then I'll be presenting on some of our improvements in terms of ambulance offload, and how we've transformed our... Oh, I'm not loud enough. Sorry. Yep. And then I'm going to talk about how we've transformed our reliable patient management system into our daily safety operating system. And so what I'd really like you to take away from my presentation is how we at Northern Health have changed the discussion from access to safety. So who are we at Northern Health? So we're a metropolitan health service in the north of Melbourne, surprise, that has 4 sites. So we have a 54-bed emergency department. We've got 5 resuscitation bays, 9 paediatric cubicles. We've got a 23-bed short stay unit and 306 adult multi-day acute beds. So the community that we serve are culturally and linguistically diverse. Having been born in 184 different countries, that's out of a possible 196, and speaking 106 different languages. We try really hard to provide culturally appropriate care to our patients, which is often challenging given they follow 90 different religion or belief systems. We have over 40 in-house interpreters covering more than 20 languages to try and provide this culturally sensitive care. And unfortunately, we have high levels of socioeconomic disadvantage in our community, and some quite challenging health behaviours. So an example is that the rates of smoking in our community are 15.3% versus a 13.1% state average. And with such a large proportion of our community having been born overseas, their healthcare perception is often very reliant upon hospitals, because they haven't been exposed to or had opportunities to access high quality primary healthcare. So anytime they feel the slightest bit unwell, they call an ambulance and come to the hospital. We're finding that quite a challenging behaviour to change. We also have the additional challenge of exponential population growth, with 3 of Victoria's fastest growing regions located in our catchment. And so all of these factors contribute to significant demand for our emergency department. And so this year we're projected to see just under 107,000 emergency presentations, which is a 7.5% increase on the year prior, which was a 7.9% increase on the year prior to that. And so when I attended the Winter Symposium put on by the department this time last year, we'd had a couple of terrible days where we'd hit 300. 305 is business as usual these days, and a really bad day is 360, 370. So we're growing so quickly that what used to be, what 12 months ago was super challenging, is now just the norm. You get really desensitized. Similarly, our inpatient separations are growing exponentially. So we're projected to have 117,000 inpatient separations this financial year, with similar rates of growth in both elective and emergency separations. But at least that slowed down to only 9%, which is better than 12% and 17% the year before that. So, you know, things are looking up. So what does this year look like at Northern Health? So like I said, about 107,000 emergency presentations, 32,000 of which will arrive by ambulance. And then there's 74,000 walk-in presentations. So about 50,000 of those will be admitted. And then we've got 56,000 elective admissions plus 11,000 women having babies. So that gets us up to our 117,000 separations. And if you just look at the multi-day patients in the box, you can see that 20% of them are being admitted for management of a chronic disease, so COPD, heart failure, diabetes. But the really striking thing is that 40% of those patients that are admitted for a multi-day, that have a multi-day admission, have a chronic disease that's not currently managed in that admission. So it just goes to show how heavily comorbid these patients are and how complex their care needs are. So if anyone's got less challenges and they're looking for a head of respiratory, just come give me a buzz. So despite these quite significant challenges, we are 100% committed to improving. And one of the areas that we have committed to, or that we have committed to improving and have sustained improvement in, is our AV offload time. So at the end of the 15-16 financial year, Northern had about between a 70 and 75% AV offload rate, and we decided that we needed to improve. So we identified 4 main issues that were impacting upon our performance. So a lack of available space to meet AV offload demand, a lack of transparency of real-time performance, insufficient staffing to support AV offload, and then a lack of clarity of definitions and role responsibilities between the AV triage nurses and the ANUMs. So insufficient cubicle space, well, so there was no dedicated space to offload ambulances, which was resulting in overcrowding. So what we did was to convert 2 sub-waiting areas within the department into dedicated AV offload spaces. So when we started, we had 3 cubicle spaces in 2017, which expanded to 6 in winter of 2018 to sustain our performance. We also identified a lack of real-time offload performance. So there was poor visibility of pending AV arrivals across the department as a whole. So individuals might know, but there was no clear transparency. And we also identified that there was poor data integrity with significant discrepancies between what AV and Northern Health had documented as the offload time. So this led to the development of our AV Arrivals Board, which displays both the acuity and the ETA of the pending arrivals on 5 large screens across our department. We also developed an AV offload dashboard on our reporting portal, which provides real-time AV offload data and is checked at the end of each shift by the ANUM. Finally, we implemented a new system whereby AV and the offloading nurse together agree on the offloading time to be documented to improve our data integrity. So in terms of our staffing resources to support AV offload, so we recognised that there was no dedicated staff member to do this, which led to the development of 2 nursing roles. So the AV surge offload nurse, whose responsibility it is solely to look after the patients in the AV cubicle between 9 o'clock in the morning and 2 o'clock in the morning, in shifts, and also an AV triage nurse. So from February of 2018, there's also an access physician between 9 o'clock in the morning, 8 o'clock in the morning and 11 o'clock at night, predominantly Monday to Friday, but sometimes on the weekends as well. And so they're responsible for maintaining flow across all modules in our emergency department. So they can decant patients to the short stay unit, the observation unit. They can be an extra resus consultant in periods of high demand. And then they take all of the calls and do all of the work that interrupts the work or the workflow of the doctors on the floor. So they'll take calls from pathology, referrals from GPs, calls from clinic for patients who need to be admitted. And they escalate to difficult inpatient teams. Yep. And then the third position was the ED flow nurse, which was created in March of 2018. So that's a 24/7 position whose role is to, by 90 minutes, determine the patient's final destination, whether that be home, our short stay or observation unit, the Broadmeadows Hospital, or the Northern Inpatient Wards. And then finally, we recognised that we needed greater clarity in role definitions and responsibilities for the AV triage nurses and the ANUMs, so who was meant to be doing what work. So it was identified that there was significant variability in the time taken for triage, so between 20 and 45 minutes. And so clear role descriptions for triage nurses were developed and individual performance assessed against a 10-minute KPI. So all staff undertook a triage competency package to standardise their triage practice, and individual coaching was provided to help individuals achieve their goals. And it's really important that all of the nursing staff did really want to achieve their goals. So once they achieved it, it's monitored quarterly. So we have quarterly timeliness reviews of performance so that everyone can maintain and continue to improve. And then to maintain our triage timeliness, all of the emergency grads undertake the ETEC as part of their course and learn standardised triage. So our performance has been sustained. So in 2017, we had significant wins because it was a bit easier to go from not very good to good. And so we saw a 5.6 minute reduction in our AV offload time. That might not sound like a lot, but that's across 27,531 arrivals. So that equates to 2,570 hours that ambulance crews were able to be back in the community caring for the patients out there who needed their attention. So that's the equivalent of 257 10-hour ambulance shifts. And so in 2018, we were able to sustain this performance and continue to improve slightly. So we managed to reduce by a further 0.46 minutes. And again, that's across 30,000 ambulance arrivals. So that's an additional 233 hours of ambulance time back in the community, or an extra 23 shifts. So how did we succeed? So fundamental to our success was staff ownership. So we had to change the focus from the unwell patients in our department to the unwell patients in the community who were waiting for care. And because it was patient safety focused, there was tremendous buy-in from staff. And staff were genuinely interested in feedback, which was provided to them regularly through audits and huddles. It required strong leadership from our ED leadership team, both medical and nursing, as well as significant exec support. And there was clear expectations and accountability for individual performance, with a focus on continuous education and improvement. Okay, so that's the front door. Now what are we doing to change what's happening on the inside? So Northern Health was a relatively early adopter of the tiered huddle system for Victoria. So we implemented our reliable patient management system about 2.5 years ago. And so like most health services, this is the system that coordinates operations on a daily basis across the ward at a tier 0 and 1 level, and then across the site or organisation at tier 2 and tier 3. But after 2 years, we found that we weren't really getting the quality and safety outputs from the tiers that we desired and that we had initially found. And we realised that we'd lost focus on quality and safety due to quite significant bed pressures, and we'd become completely preoccupied with access and flow. So Northern Health is on a journey to become a high reliability organisation. So high reliability organisations are organisations that function in potentially hazardous environments but have lower than expected adverse outcomes. And examples include the nuclear power industry and aviation industries. And so there are 5 key characteristics of all high reliability organisations, which are alertness to risk, reluctance to simplify, a sensitivity to operations, deference to expertise, and a commitment to resilience. And so Northern Health uses these key principles to drive our daily safety operating system and to allow us to focus on providing trusted care for our community. So we decided we needed a more sophisticated understanding of both patient and staff safety across our organisation on a daily basis. We needed to capture and record key safety measures, and we wanted to have a continued focus on flow, but from a patient safety perspective, and to have clear expectations of individual roles and responsibilities. We learnt from other healthcare organisations with a visit to Peninsula in Victoria as well, and then did an extensive review of the literature to see what other high reliability organisations were doing in this space. Welcome to the Daily Safety Operating System. So by the end of the Daily Safety Brief, which is at 9:45, we have taken the pulse of the organisation and have a clear understanding of the overall safety status of the organisation. And I know that you're all thinking, oh, it's exactly just like Tiered Huddles, but it feels really different. It's a complete change. So we continue to have our unit MDT meetings every day. This is not really any different, undertaken at a ward level with the medics, senior nurses and the multidisciplinary team. It's usually at 3 o'clock and the team answers the same question. What is keeping this patient from going home or to their next most appropriate care destination? We document the estimated date of discharge and highlight any barriers to either the care, safety or discharge. So then the following morning, the daily safety walk around occurs between 8:30 and 9 o'clock. And this is for all inpatient and clinical areas with an operations representative. And so this is a check-in on the overall safety status of each area, which is then documented on the safety portal, like you can see on the side there, by 9 o'clock. It's also completed for all non-clinical areas as well by a shift leader or a senior representative. And so by the end of the safety walk around, we've got a clear, the safety status has been agreed and has been completed on the portal in time for the daily safety brief at 9:45. So the daily safety brief kicks off at 9:45, like I said. So this is the meeting that replaces tier 2 and tier 3. And each area gives a short, sharp 30-second report, which allows us to identify safety hotspots across the organisation. So if I did the Division of Medicine, it would be, hello, Catherine, I'm reporting for the Division of Medicine. Our overall safety status is green. We've had 3 8:30 discharges with 5 confirmed and 5 pending. We had 2 patients with multiple met calls overnight. One of them has been transferred to intensive care. The other one has a clear plan in place. All of our watches have clear plans. There are no other safety or patient or staff safety concerns identified at this point in time. It's a whole division done. Like, it's snappy. Ooh, I've got to be snappy too. Okay. It adds value by fixing things in real time, logging issues, and continuously improving. And it aligns with our HRO principles of sensitivity to operations and alertness to risk. So by the end of the daily safety brief, we've literally taken the pulse of the organisation and have a clear understanding of its overall safety status. So the safety brief is chaired by a senior exec and the safety officer of the day. So it's usually chaired by our Chief Operating Officer, Jane Poxton, who's in the corner there. And the safety officer is a senior doctor. So both are there to support areas reporting as amber and red, and to help them resolve the issues raised. And the safety officer is easily identified by the horrific lime green badge. So this is the agenda. So every single one of those areas report out, and it's all done in 15 minutes. I can only think of 1 or 2 times it's run over. So in terms of the benefits, it provides the new system has allowed solutions to safety issues. For example, the ECG machine in cardiology isn't working. The workstation on wheels that the junior doctors use to do the discharge summaries is broken. So IT can go and fix it immediately after the round. So it's sped up all of those processes. And it has identified and created awareness of the safety hotspots in the organisation by breaking down silos. So one of the most valuable things is actually the safety officer who's able to support plans for the watches. So the watches are the organisation's sickest patients that staff just have a gut feeling might deteriorate. The safety officer, if anyone is concerned, is able to go and help sort out that problem and escalate appropriately. It also provides us with an understanding of all areas and what's going on in those areas. So we understand that if an area's got really high acuity, they might be slower at flow. So we don't call them 30 times to say, why are you slow with flow? And we also might not put the highest acuity patients from emergency on that ward. So it gives us a whole of organisation approach to safety and flow because they're just fundamentally interlinked. I've got like 2 more slides and it's really quick, I promise. So what do the staff think? We'll just not have questions. What do the staff think? So we conducted a survey of all of the staff required to attend the safety brief, and the responses have been overwhelmingly positive. So these are average weighted scores. And so they're all between 4.5 and 5, with 5 being the best, happiest, we love it, and 0 being it's terrible, get rid of it. And I think for me, the most important is this better than before? And it's a 4.8. So we definitely are going to continue doing the safety brief. So I'm skipping the next few slides. And so I just wanted to finish with what I think are key learnings about changing attitudes to patient flow. So if you want to engage clinicians, you need to make it about patient safety. We actually don't care about access KPIs. It's important to set expectations and to hold people accountable. And you need to recognise and reward teams that are trying to help. So not with coffee, but if my team creates flow, then I expect that the access managers are actually going to try to put all of my patients on my ward because that makes my patients safer. And similarly, if my team creates flow, I expect that you're going to preferentially admit my electives rather than the naughty team's electives. Yeah. And if you don't, I get cross. So I just like to thank all of the people that actually did the work that I've presented, in particular our ED leadership team and Ed Saville, who's our operations director for access, and Claire McCarthy from the Project Management Office. Thank you.
Don't go away. Thanks. Thanks very much, Catherine. It was perfect timing, actually. Well done. Who would like to ask Catherine a question about that really impressive piece of work there and direction?
Hi, Diana Badcock from Bendigo, the ED director there. Your naughty teams, I'd like to know a little bit more about them. I think, you know, front-loading care with the senior clinical leaders is certainly the way, you know, the next, it's the elephant in the room, if you like. But the naughty teams, what do you think is different about their inability to participate in the change in safety culture and therefore flow?
So for us, I think the naughty teams, our model of senior doctors has always been very VMO driven. And so particularly for our surgical teams, their consultants just aren't there. And because of that, they're not invested. And so it's difficult to get them to engage. Whereas in some of the more medical specialties, we've got more staff specialists, full-timers, and so they are more invested. And actually, when we look at where our not wasted bed days, but excess bed days are, it's not in the Division of Medicine.
So do you think the VMO model needs to change to more reflect the specialists model?
When I rule the world, 100%.
Beautiful answer. And probably quite realistic. Yes. Yep. Oh, yep. Thank you. Yep. Thanks for waiting for the mic, everyone. Everyone's been fantastic.
That was a great talk. Thanks very much for that, Simon from St Vincent's. One of the points on one of your slides, you had patient acuity, and I think even in discussions yesterday, that's a common thread that it's quite hard to really get a somewhat objective pulse on that. Can you talk a little bit about how you've done that at Northern, and perhaps what's worked and what hasn't worked?
So our system is quite new, but it's just a gut instinct. So because clinicians generally know, like, there's something just not right with that person. And so that's why they're called watchers. So there is no objective measure, and you're allowed to have as many or as few watchers as you like, as long as the criteria for that is clinical deterioration. So we have other, if you've got a lot of high falls risk patients, they're not watchers. Like, it's the clinical deterioration that you're worried about. So we've been clear to define it in that particular way, but we're not being super duper strict about what people put in that category.
Any other questions?
Good.
You will join with me, please, and thank you. Great stuff. Are you going to self-serve too, Cameron? Yeah. This is the life.
Thank you.
Yeah, you might just have to. Why don't we just escape it? Yeah. And yours will be there somewhere. Great. So while Cameron's moonlighting as the AV person, I will happily introduce him. Cameron has a wealth of experience in health leadership roles, including ED of Acute Ops and Director of Medical and Emergency Clinical Services at St V's. He's led a service improvement program with a strong focus on clinical engagement and building leadership capability. He's a nurse with an MBA, but we won't hold that against him. Welcome, Cameron Goodyear. Do you want a pointer? There's a laser pointer if you want it as well.
Thank you. So hi everyone, and thanks for the opportunity to present today. And the title of my presentation is Leading with a Green Thumb. And I most will not be talking about gardening or horticulture, but what I am going to talk about is cultivating leadership, building staff capability at the front line to support sustainable change and improvement. I guess really at St Vincent's, this has been fundamental to our improvement journey over the last couple of years. So I'm going to talk about this, and this foundation's really been important in terms of leading to the multiple improvement initiatives that we've got going on, most of which, or some of which, I'm going to highlight today. I guess what I also wanted to say was I have the great privilege of being able to present this today, but really the real credit goes to the many staff at St Vincent's who have been involved in this improvement journey. So some of the staff in the room and many of the 6,000 staff that are actually back in the hospital today, living the reality of the challenges that we're dealing with and we're working on overcoming. So the real credit, the recognition and the accolades from what I'm going to talk about today go to them. So I'm going to start with a quote. So many leaders attempted to lead like a chess player, striving to control every move, when they should be leading like gardeners and creating and maintaining a viable ecosystem in which the organisation operates. And I guess that quote came from Stanley A. McChrystal, and not many people in the room will know who he was. He's now a retired US Army general. He realised that traditional command and control hierarchies in the military were ineffective, in particular in the heat of the battle, where sometimes the leadership's not available. And he really challenged the traditional vertical relationships where decision-making flowed and really only flowed down and in silos. And he really worked and challenged the military in regards to teamwork and I guess the supportive cross-functional relationships that are required. And I like this quote because it's really been fundamental around and it's parallel to what we're trying to do at St Vincent's. The role of leadership at St Vincent's is not really about command and control. We're really clear on this. We focus on creating the right environment and I guess maintaining an ecosystem where problems and challenges are firstly visible, and then we create a culture and a shared ownership where together we deal with them. What we strive to do every day is really to allow our clinical leaders to flourish, so the doctors to do the doctoring, the nurses to do the nursing, and really to enable them to be their best and bring their best to provide value-based patient care. And for us, really, it's pretty simple, and it's essentially my role as part of the broader executive and the senior leadership group to ensure this happens every day. So I guess this is a highly stylised view of the whole of hospital, and it's very actually similar to Shaman's slide that he had yesterday around the whole of hospital view. All roads lead to home eventually for our patients, and I guess each patient's journey is different, and I guess each patient's connection with the health service is different. Patient's journey can meander, or it could be straight home from emergency in 3 hours and 59 minutes, not a minute more. I guess the components of the system have to work together and work together for the system, and there's acknowledgement that there's an interconnectedness, and issues at one junction can lead to issues upstream or downstream. So I know I'm preaching to the converted in regards to this, but I really just wanted to acknowledge that we're all in it together and I guess have the same challenges. So I guess patient flow at St Vincent's. So we have a system level structure for support and direction for our staff, really trying to create that real awareness of the need to be interconnected. The systems and the processes that support the meandering patient journey need to operate with a level of cohesion. And I guess where there's problems and blocks, we want this to be visible, and that's fundamental to what we're trying to do. And where issues can be solved locally, we work towards empowering our staff just to get on with it. Where they can't be solved locally, we want to hear about it, and that's where our support comes in. And so the structure essentially promotes real local ownership, which leads to sustained improvement. And I guess you must be sitting there thinking, what is he actually talking about? And really what I'm talking about, and it's probably going to echo some of Catherine's talk, is our daily management system. And really that's been the key sort of cultural way of being at St Vincent's to support it and has supported our improvement. Fundamental within the daily management system is we listen to and empower our staff and our clinicians, and we want to hear the problems. So we encourage and support local problem solving, as I've mentioned, and we provide the opportunity for escalation and support where that's required. And the structure supports deployed direction and planning, and so we aim to create an awareness and ownership of our direction, and so our staff are really clear about what we're trying to achieve. And we try to operate across the silos and ensure that everyone's really clear on their part to play in terms of our patients getting timely care. So you can see our sort of tiered structure, which is very similar to what Catherine overviewed. So we have a tier 1 structure, which is all our frontline clinical areas. They essentially huddle every day. There's a discussion around the plan for the day. There's a collaborative discussion around whether the area is good to go. If not, why not? Can the issues be resolved locally? And then we have an escalation. So if issues can't be resolved locally, they come up to the tier 2 level, where that's a daily meeting consisting of our general managers and the clinical executive. And so where we work together to try and resolve some of the issues or the barriers that we're seeing within the day. Then that couples up to the tier 3 structure, which is a weekly meeting attended by our CEO, all of our exec and all of our general managers. And so that's essentially a weekly report out around all of our metrics around safety, quality, delivery and performance, people and cost. And this essentially allows us to track performance, but importantly, inherently within that, it promotes accountability, and it also enables shared ownership and organisational support for our challenges. So, investment in local capability and ownership leads to improvements. And I guess all the stars in this slide are trying to represent all of the work that we've got going on across the continuum of care. And it's not an exhaustive list. And I guess it's been acknowledged there's no silver bullet to improving timely care for patients. It requires multiple focuses in a truly whole of hospital approach. So some of what I'm going to overview now is some of the very short improvement stories. It's going to be a bit of a sort of a speed dating session. I'm going to take you through a number of initiatives, fit one way speed dating session, but very happy to hook up in the break after in the morning tea to talk a little bit further. And I know my team are very happy to hook up and talk about a lot of the work that we've done to date. So some of our emergency department initiatives. So this is really one, so this is obviously with the support of Andrew Walby, our ED director, but led by the team within ED. And so the problem was that we were not where we wanted to be in terms of our non-admitted ED performance. And so one of the key initiatives was to implement a rapid assessment team. So really that's about an additional consultant, additional nurse, supporting the peak periods in the afternoon to deal with that non-admitted stream, and having a focused area of the emergency department to support that and enable that upfront decision making and that early definitive plan of care. I guess what that's helped us do is improved our performance. We've tried to really match our staffing to the demand that we see in ED. You can see there over the last 12 months, that's resulted in a 21% improvement in our non-admitted ED performance. In the setting of no growth, we would have actually improved our NEAT by that. But like other health services, as you get faster, as you get better, what happens is more patients come. And so we've continued to grow at the same time. So our NEAT's around the 72% at the moment. That's what we achieved in Q3. And we're not competitive at all. We're still trying to challenge the Alfred in that respect. We're still the top of the tertiaries. But this has been one real key linchpin for us in terms of improvement of that patient stream. Our other piece of work has been around our admitted stream through the ED. And I guess that piece of work wasn't led by the ED. That piece of work was led by, facilitated by Jess Kennedy, one of our respiratory physicians, but led by our clinical leaders, so our head of surgery, our head of medicine, and our chief nursing officer. And I guess the approach was, we knew that we had unnecessary ED length of stay for admitted patients. And we firstly established a very large medical and nursing working group. So it consists of different levels of clinicians in the organisation. We ran a number of workshops to really get clear on what the problem was and what we're trying to achieve. What we learned from that is we really had an inconsistent process for the ED admission process, and even around deciding the most appropriate unit for admission, the actual process varied. And so out of that, we established some key principles and really standardised our approach for the admitted process through the emergency department. And you can see there, we implemented this in February with the change of the clinical year. And can you see there some early numbers around how we've been able to improve, and in particular bring more patients closer to, you know, zero to sort of 8 hours, and then limit the tail and limit that unnecessary long length of stay in ED. One of our other key focuses has been the ambulance offload performance. So our ANUM in ED led this piece of work, and so we established a cross-functional working group really to look at what the issues were, look at the variation that we had in process, and really get clear on the roles of the ED, and in particular ambulance offload support function. We established an escalation around where we do have delays, that gets supported not just within the ED but outside of the ED, in particular with our bed management teams. But really key and fundamental to this was around the why, so what we were trying to achieve with this KPI. You know, really what it was about returning the ambulance back to the community. So a bit back to Anthony's presentation, really what you know, for our staff to invest in this, they really wanted to understand the why. And I guess for us, what we discussed was every minute counts. So every minute that a patient is waiting on an ambulance trolley to be offloaded is every minute that potentially the ambulance can't respond to a 000 call. And so really that gave the staff a higher level purpose, and it wasn't just about the patient that was in front of them, it was more about the patient that's next coming to the ED, or potentially coming to the ED, that's waiting in the community. Choosing wisely, so a number of health services have projects around choosing wisely, and for us at St Vincent's our focus was in the intensive care. So a project led by our clinicians again, one of our intensivists and our ICU ANUM. One of the problems that they focused on was around unnecessary chest x-rays being completed, and also unnecessary observations for arterial blood gases, and unnecessary observations for patients who are ward ready, and also blood gases being completed on ward ready patients. And you can see the improvement there. I guess I was looking at it earlier and I thought if that's my share portfolio, I'd be very upset, but the actual improvement, so if you see there around routine chest x-rays per patient, so we'd established a process in ICU where, 5 a.m, the majority of the patients would get a chest x-ray, and purely that just became a routine, and no one actually challenged the clinical significance as to that being required. And it simply sat down and to work through that process with the clinicians, and what we identified, there was a lot of wasted tests being completed where clinically the patients didn't require it. And what it actually did was freed up obviously some radiology and radiographer x-ray time, which actually supported our ED to get better access to x-ray. And then you can see around the hourly observations, so in ICU, patients who are waiting to go to the ward were still having hourly observations. When they hit the ward, they're not, they'd be on the 4-hour observations. And so, we really made it clear when patients are ready to move to the ward that didn't need to be continued, and there's return time to care for our ICU nursing team. I guess one of the surprise packages, I love it when you come to work and you get a pleasant surprise. This project around acute spinal length of stay wasn't on our plan to do, and it was actually self-initiated by Lucy Stone, who's one of our neurophysiotherapists. And she identified that compared to other health services, we've got a longer length of stay for spinal fusion. And one very simple countermeasure that she implemented was not just early mobility, but mobilising patients on day one twice. And so doing that the first day post-operatively twice, and really focused on that early intervention in that space, improve the length of stay, and you can see the benefits there around length of stay. So we measured the length of stay in hours. She was really keen. For her, every hour counted, and you can see the improvements that she was able to get with length of stay, really just associated with a simple change that she self-initiated. Countdown to discharge. So this is around our acute length of stay. So all of our nurse unit managers were involved in this project and been involved in this project. So we established some key principles for the hospital to roll out. We developed and trialled these in our Gen Med ward first, and then we established a NUM improvement community of practice where some of the learnings and the experiences can be shared across all our nurse unit managers. And we really focused, again, it wasn't just the nurses leading this, around the clinical engagement and that shared ownership across the multidisciplinary team. So really simple, I guess, principles that we established. So there was the multidisciplinary daily engagement around our Tier 1 structure, the estimated date of discharge being sent on admission and really trying to be maintained and updated. The EDD, or the estimated date of discharge, being visible to all staff, including the patient, and the daily process of review by our multidisciplinary team, and then a written standard around what should occur when, and very simple things like discharge scripts being done the day before. So I guess, it wasn't a rocket science project, but again, it required the collaboration, the ownership of all the nurse unit managers to make it happen, and you can see some of the results around our acute length of stay to date. Elective surgery access for us, obviously like other health services, is important. This project was led by our perioperative services manager, our elective surgery access manager, and a number of our key surgeons. The problem for us is we weren't treating patients, our elective patients, within the time that we wanted. And so one of the key opportunities was around our theatre utilisation and actually looking at how we build our theatre sessions. And so we established the standard for that, in particular getting an awareness around the inflow, particularly for patients being added to the waiting list from clinics, and also developed some standardised principles and tools around the way elective sessions were booked and planned for. We obviously continued the focus around our long waits and on balancing that with patients coming onto the waiting list. And we were really clear that of the role of our Tier 1 structure in the theatres was really around problem solving. So in the morning, why did we have late starts in the operating theatre? And from the prior day, looking at the turnaround times of those lists and any overruns, and what were the reasons for that. And so you can see just with that, we've improved our patients treated in time from the waiting list. Really with the main focus being around our theatre utilisation. One of the things we've had lots of discussions about, and I guess it was sort of picked up in one of yesterday's discussion, it was around what should our measure be around elective surgery, and should it be the waiting list, and really is the waiting list an arbitrary number? And for us, is 1,000 patients, or the number, or is 43,000 the number, which is around the number for the state at the moment. And when we ask our clinicians, they don't really care about what the waiting list is, they care about their patients being treated in time. When we ask our patients, when they get added to the waiting list, what's the first question that they ask or want to know is, how long is it going to be until I'm treated? And so for us, the key metric is patients being treated in time. Acute to subacute flow. So I guess we had various stakeholders involved in this project. So for us, patients waiting for a subacute bed was longer than we would like. And I guess when we looked at this, the process was not clear or commonly understood around how patients move from acute to subacute. The status of patients in the assessment process and their readiness was unclear at various stages, and we didn't have a standardised process for referral assessment, and so we established that as part of the project. And we made it, I guess, the invisible waiting list visible to our clinical teams and all of the multidisciplinary team, and part of the enabler of that for that was our electronic journey board. We're able to see patients who have been referred, and we're able to track their referral status and waiting times. And so you can see there our improvement around referral to subacute transfer. So I guess for us, the list goes on, and these are a number of our other improvement projects that we've got underway, all locally identified and managed by local teams. One thing we have at St Vincent's is we don't have steering committees, we don't have terms of references, we don't have separate governance structures for projects. We have steering committees, but they're actually executive huddles, and so short and sharp levels of support provided from our leadership team. And we use our organisational structures and in particular our business owners being accountable. So we do have a bias to action. We have lots of PDSAs going on across the organisation, but really what we try to do is make sure we have the right support in place to support improvement. Thank you. My last slide. So where to from here for us at St Vincent's? I guess for us maybe it's a bit about more gardening. So we have a focus on being better gardeners, and what I mean by that is really for us it's about building broader and deeper organisational capability for improvement, improve the clarity of direction for our teams, and improve our systems to better support and make it easier for our teams to thrive. And at the end of the day, our patients will be the beneficiaries. I guess a lot of my presentation today has been a little bit internal focused. And one of the opportunities for us is at St Vincent's is extending our garden. And so we're doing some work at the moment looking at care outside the hospital walls. And so we'll be interested in looking at the presentation later today from the primary healthcare group. And also our relationships with other hospitals. And so in particular, rural and regional Victoria, and ensuring our role as a tertiary centre that we support timely care for access for patients in rural and regional Victoria. So I guess in closing, we look forward to continuing to nurture where required to support the forest to grow without the trees falling over. And at times we might need a bit of fertiliser to stimulate action, but more often than not our structure and improvement approach allows this to happen on its own, and so we hope it eventually actually has a life of its own. So thank you.
Thank you very much, Cameron. Lots of great stuff there. Would anyone like to ask a question or make a comment? Yes, I have someone right here. If you just wait for the mic, please. It will be with you very shortly.
Elise from Bowen Health. I'm the Operating Service Manager. Keen interest in your project you talked about the elective surgery access unit.
Yeah.
And just, I guess, your view on the engagement from the actual clinicians, the surgeons themselves.
Yeah.
How did you go about engaging them and changing that cultural view in booking principles? We've done a body of work in that space, but it is a very challenging one. So I'm just really interested in how you managed to do that.
Yeah. Look, I guess what we tried to do with our key surgeon, and I guess what we've really done is most of our work's been on our high volume specialties. And so those clinicians, when we talk to them, they're actually really invested in their patients getting the care as timely as possible. And so what we really have tried to do is work with them in particular around those priorities. And so looking at the way they categorise their patients, but also working with them around key and fundamental was around standardising the actual length of time that they think it's going to take for the procedures to happen. And so maximising the use of our capacity and getting a mutual understanding around what that looks like has really been key. And so I guess working with them together, I guess in close partnership, has really been fundamental around shifting that forward. Yeah.
I've got a quick one.
Yeah.
Probably as a follow-up to that question, but yesterday we did talk quite a lot on and off about the importance of embedding change in line management, and I think you've shown us fantastic examples of that. and how you can't just do special projects all the time and expect it to be embedded as business as usual. So really lovely examples of that. Embedding the VMO role in that business as usual. Any success stories or lessons to share?
Yeah, look, it's always a challenge when you've got very small fractional appointments across the VMO group. And as much as possible, I guess what we're trying to do at St Vincent's is really have a key group or key 1 or 2 individuals in every unit that have more substantive appointments. And so, you know, really trying to balance having that clinical expertise within the VMO group, but have some more substantive appointments to engage, I guess, in these improvement opportunities. I think one of the opportunities with the clinical support time coming out of the EBA is that now clinicians will potentially have more time to engage in improvement activities, and so it'll be how we use that opportunity to make sure we maximise it and sort of get that return on investment, so to speak. Yeah.
All right. Cameron, thank you so much. Thank you, everyone. All right, busy morning, so you've definitely earned your morning tea. Those of you who weren't with us yesterday, follow the crowd. It is a little bit of a walk, but at least it gets the blood circulating and gets the oxygen to the brain, which is a good thing. So please start your journey back at 10 past 11 so we can start promptly at 11:15. And those who are on the panel, if you could come back around about 5 past 11 just meet us up the front here at the table, and we'll just make sure we're all on the same page about what we're going to do. So see you soon. Alrighty, hi everyone. Thank you very much for coming back promptly. Much appreciated. We have now a very interesting panel discussion coming up, giving different and diverse perspectives on timely care and its importance within different contexts, and then we'll have a bit of a shot at how we can bring all that difference into some commonality. We shall see how we go. So here I have George Jiang. George, put your hand up. I guess you're easily picked on the panel, being the only man. And George is a Consumer Advisory Committee member at Austin Health and Better Care Victoria, and a member of the Forensic Leave Panel Victoria. Thanks very much for coming, George. Robin White is the CEO of the Eastern Melbourne Primary Health Network, and prior to that was the CEO of the Mornington Peninsula Medicare Local. Robin is the chair of the Victorian Government Eastern Metropolitan Partnership and is also a member of the Department Safe Script Advisory Committee. Welcome, Robin. Jodie Bootle is, may I say, a last-minute recruit, so we say a special thanks to Jodie, as Julie Considine was unable to join us, unfortunately. Jodie is the Improvement Manager for Patient Flow at the Royal Children's. She's an emergency nurse with a wealth of experience in nursing leadership and patient flow across public health care. She's held roles at the Western Health Patient Flow Partnership as the Improvement Partner, Nurse Unit Manager roles at Northern ED and Royal Melbourne Acute Medical Unit, and Hospital Access roles. And Dr. Diana Badcock started at Charing Cross Medical School, London, followed by a brief stint in medical publishing and working in Vietnamese refugee camps in Hong Kong. Trained as FACEM on arrival to Australia, she is the Director of Emergency at Bendigo Health, an Associate Professor with Monash Medical School, and recognised for her leadership in establishing the Emergency Medical Education Training Hub for the Loddon Mallee region. Please welcome our panel. So we're going to run it a little bit like this. We're going to spend the first half talking about the now, what's important to each of these sectors represented here on the panel, and what the boulders are in the way of progress to where we need to go. Then we're going to ask you for some input into those issues, if you would like. And then we will move on to the where to from here, where we must go, and some innovation, some ideas, some things that are in the pipeline for how to get there. Sound like a plan? All right, excellent. Now I'm going to ask George to kick off for us. George, if you could pick the mic up, thank you very much. George, would you give us a brief overview of your wife's story and how that has led you to an interest in improving the quality of care?
Thank you. Good morning, everyone. My name is George Jiang. I'm a consumer representative and Consumer Advisory Committee member at the Better Care Victoria. I would like to take this opportunity to thank Timely Care Forum for providing this platform for sharing my experience. It happened in September 2015. My wife had suffered the gallbladder storm attack. She had been treated by a local GP for a week before sending her to local hospital due to her conditions was getting worse. It was on Sunday night. You can imagine how busy in the emergency department. We have been waiting for 2 hours to be allocated for a bed. Once the doctor come, he simply ask a few questions and then prescribe 10 milligrams morphine for my wife. I told the doctor, my wife never used the morphine before. The doctor then advised the nurse to give half dose of morphine through IV. In half hours later, my wife's pain still not relieved. I called the nurse. She gave another half dose. Suddenly, the alarm went off. My wife's pulse dropped from 150 per minute to 30 per minute. And her blood pressure dropped much more than normal. And all the doctors and nurses coming immediately to her bed for the first aid. So next Sunday morning, and she was transferred to the day surgery center. Due to a lack of medical information, my wife has to undertake all the tests, such as a blood test, ECG, ultrasound. The ultrasound result shows that one of the stones stuck on the neck of the gallbladder. The gallbladder was severely swelled as an eggplant. And she was on the top waiting list for the surgeon. When the doctor came, I raised my concern. I say to the doctor, in my wife's conditions, first is to stop the pain. Second is to give her more antibiotics to treat inflammation and also to reduce the risk for post-surgery complications. And the third, be quick for the operation. But unfortunately, she is waiting for 2 days in the day surgery center, and Tuesday afternoon, she had a surgery. After the operation, the doctor give her the 3 strongest antibiotic for her treatment. She has to stay in the hospital for a week, and then took 2 months for full recovery. So in this case, I learned firstly how important in communications. If the patient in serious conditions or non-speaking English background, the doctor should ask more information from patient, from care, and from family member. Secondly, the personal medical file should be shared between GPs and medical service provider in order to get more information about the patient. Third, the doctor needs to upgrade the knowledge for a better treatment on patient. That's it.
Thanks. Thank you very much, George. And that's very succinct, but very to the point and very powerful. So there's lots of issues there, obviously, for you. There's a definite timeliness issue. There's an information sharing issue. There's a role of the patient issue, and a few other things, I guess, a few other clinical issues there as well. All wrapped up in connected care and how we make care more connected and more continuous. So thanks, George, for setting the scene for us. So I'm going to ask, I'll start with you, Jodie. From a nursing perspective, why is timely care so important from a nursing perspective? And if you could pick up on any of the issues that George raised as well, as part of that, that would be fantastic. So just as a kind of an overview to start, what is the issue in terms of timely care, because 30 years ago we didn't talk about it. So how come it's such a big issue now?
Yeah, timely care is extremely important from a nursing perspective. I'm sure probably the nurses in the room would agree that we have a lot of non-value added time as a nurse waiting around for lots of things. And that may be plans of care or patients waiting to be discharged and stuff like that. George raises a really good thing about communication, and there's certainly lots of innovative ideas out there about how we can certainly improve our communication to patients. Whether that's cyboring or multidisciplinary rounds or short, sharp rounds. And someone raised a good point yesterday about their loved one shared their story 5 times.
Yes, that was me.
Yes, yes, it was you, Kathy, about sharing their story 5 times. So there's a lot of space to be improved in communication. From a nursing perspective, they're the frontline people. They get to see the patients 24/7. They get multiple visitors, and improving that communication to the patients and to their family is really important, because they do cop the brunt more times than not. I think especially in your perspective, George, from a consumer's point of view and from a patient's point of view, improving that communication is important. I think sometimes it's good to put yourself in the shoes of the patient, and what would you like to receive, and how would you like to be communicated to as a patient. So certainly from nurses, I think if we improve that space, we will be able to provide more timely care. If we changed our process around, became more innovative in how we can actually get patients through the system, we would probably see our quality improve, certainly, because we want quality, timely care to, and access to care. So.
And interesting, Jodie, I mean, you know it, but sometimes you don't think about it specifically until someone says it. But poor communication is very, very bad for the patient and very, very bad for the staff.
Yeah, absolutely.
Because it's not allowing you to do your job.
Yes.
And it's not contributing towards timely care. In fact, quite the opposite.
Yeah, absolutely. And we can probably save, and certainly from an improvement space, we can become more efficient and effective in how we provide that care to patients.
Yep, fantastic. Thank you very much. Robin, a lot of people in the room might be thinking, what's a PHN person doing here? What do they have to do with timely care? So what do you have to do with timely care?
Thanks, and thanks for the opportunity. I really think it's important to consider this issue from a primary care perspective as well as a hospital setting perspective. The very words connected care really needs us to be thinking across the service system, not just within our current workplace. And in fact, the mantra of PHNs is right care, right place, right time. So that timeliness of care is incredibly important. And in the primary care sector, it's one of the enormous frustrations that clinicians have. And I can talk a lot about GPs and the sorts of issues that they have in terms of understanding and gaining information around their patients. Because I think we'd all agree what we want to do is keep people in the community, well and in the community as long as they can. Obviously, when people need a hospital, they need a hospital. But there are lots of occasions where we can intervene earlier or with a different mechanism in the community to prevent people falling into the hospital system. So from a primary care perspective, there's a few issues. Communication and the inability to securely transfer electronic information about clients between clinicians is perhaps the biggest issue, and for me, it's a mounting frustration that I hear from not only GPs but hospital sectors as well. And we really need to be putting some effort into ensuring that we've got secure messaging that enables that transfer of information between the care settings, because It's in between, it's transferring between care settings where patients get into trouble. They fall through the cracks. That's where the problems occur. And that introduces enormous delays in service provision. If we have an ability for a clinician to view an entire relevant piece of clinical information about the patient sitting in front of them that works across those settings of care, then obviously there's going to be a much better chance that we'll be able to treat that patient well and appropriately in a community setting. So that disjointed communication between those settings, I think, is an important one. But I think there's also some issues in terms of how we've set up the service system. We have hospitals, we have GPs, we have allied health that are all working in different settings, we have some community funded services, but there are real gaps in the service system, particularly in the after hours, and particularly for mental health clients, that's where there are big gaps that you can observe most easily. For mental health, there isn't much between a hospital setting and a community mental health service, and sometimes we need different venues and locations for people who cycle in and out of being well or unwell. But it's really the communication and information between hospitals and GPs that I think is worthwhile thinking about.
So you've really got a bit of a helicopter view. I mean, everyone looks at things through their own lens, but you do tend to be able to step back and see that bigger picture.
And we're actually trying to support the service system along many of those lines.
Yep.
So we do quite a lot of work around e-referral, secure messaging, discharge summaries and improving the quality of those discharge summaries. And we also collect information from GPs and primary care settings to enable us to have an evidence base to work with our hospitals around what improvements we should make in that connectedness between the acute setting and the primary care setting.
Yep. I'm a health information manager by trade, and discharge summaries have been an issue, well, as long as I can remember, and that's a pretty long time. So sometimes I wonder if perhaps we should start thinking about something different, because they're proving very, very elusive in terms of nailing what we need. Thanks, Robin. And of course, we didn't design the health system. We didn't set it up the way it is. It's just evolved, which is part of the problem, of course. You wouldn't design it this way if you were starting from scratch. Diana, we've heard from a few ED people in the last day or so. So what's your perspective on where the problems lie?
So the emergency department was sort of designed and loved by the people who work in it as a place for the undifferentiated, acutely unwell or a trauma victim to turn up. But by default, it's become the safety valve of all the failures in the social and healthcare system. The front door to access all of the services that you need. And what George describes is what matters to him is a wife that's already been diagnosed with a condition that needs treating and now needs some antibiotics and some analgesia. And by default, the process by which he tries to access that is through the emergency department, whereas in an ideal world, we should be able to get those things to him until the moment he needs his surgery, she needs the surgery, and we can deliver that care and then get her home the same day. So we've produced this sort of safety valve with a paternalistic overtone that come to us and we will fix all. And the more people that come, they will keep coming and we will fix a little hiccup that we see that we can fix. But it will be a never-ending tsunami until we bring the humanity back into the healthcare we deliver and we actually listen to the population we serve. So I think all that we hear is a perfectly designed system that we've created, and then we stand back aghast at the fact that we can't cope with now what's coming our way.
Yes, every system is perfectly designed to get the results it gets. That's interesting, your comment about a paternalistic view. I think that's part of the problem in healthcare generally, isn't it? That we're very hierarchical. We are very paternalistic. We've evolved from we know best, and shifting that is proving extremely difficult. But I think it's an important part of the timely care and all quality care conversation. And that is, it's a fundamental mindset set and culture shift. But to make that shift, everyone needs to want it. And I don't know if we're quite there.
No. So if there isn't timely care, of course they're going to turn up if they can't access their cardiac rehab or their operation. So probably the 30% of people that is being quoted as people who don't need to be there, it's just a cry for help because they have no other way of accessing it.
Yes, yep, thank you. So George, what was the one thing that you saw that was blocking the kind of care that you really wanted for your life? You know, if you had to pick one thing out of that episode, what was the thing that, that is the problem? What was the big thing that you thought, this is the thing that is stopping us getting the care we need?
We all understand that going to the hospital is not a good feeling, regardless physically and mentally. Especially in the emergency department, it's everywhere it's look like a chaos. You can see from the movie, from TV series, but in the real world, yes, it's like that. So lucky if someone come in straight away to look after you or look up your family member. It's more important. So. I'm working in the casino. I've been casino host for 11 years. I can't compare with the hospital or the emergency department service with the casino service because we treat all patients as a VIP. You have to know the names, you know what they like. In the hospital, it's impossible. But can we do any better? First hands to allocate patients based on the conditions for the bed, and then very carefully to ask more information from patient or their care. A lot of times, I know the nurse and doctor know patients to ask more questions. Even the family member has been denied to provide any information. And this, I have seen this service being denied, not family member providing interpreting, have to be interpreter. It's not quite right. A lot of times the family member doesn't want the patient to know the details in certain circumstances. Yes.
Yep, so that, that personal care, that treating people like an individual, a valued individual, and the role of family, which of course varies from consumer to consumer. Certainly when my stepmother was in hospital, which I was talking about yesterday, I felt at times that I was sitting by her bed behind a clear perspex wall. The staff could see me, but it didn't matter what I said. They couldn't hear me. It was very interesting, very, very interesting. So George, if it's any comfort at all, we all go through it. when our loved ones are in hospital. And I did like your comment about, you know what an ED is going to be like because you see it on telly, except in real life, people aren't quite as good looking. Oh, as a joke. It's a joke, right? Of course, you're all beautiful. Jodie, big boulders. I mean, you know, you've seen an awful lot of this. If there was one boulder you could blow up that's standing in the way of real progress to timely care from a nursing perspective?
I think patient progression through the healthcare system is quite complex. But I think for me personally, it's about how do we prevent patients from coming into hospital? What in the community is there to assist them? If you were to step in the shoes of a patient, if you go to the emergency department, you're going to get seen within 4 hours. You're going to get free medical, you're going to get free pathology, you're going to get free x-ray. If I was to go to my GP, that time would be 5 to 6 days turnaround, and I have to pay for this service. So to a degree, you can't hardly blame someone who really doesn't have much money coming to the emergency departments. How do we prevent them from coming? How do we make our community services more, I suppose, affordable, quicker? People are anxious. They just want a diagnosis and they want treatment. So do we blame them from coming to EDs? No, we don't. But then to get patients through the hospital system, we also have to be efficient at the other end. So from a nursing perspective, and we spoke about trust yesterday, we have to trust nurses. I'm a bit of a fan of criteria-led discharges. I believe there needs to be more criteria-led discharges. It's still driven by medical, but there's also very experienced nurses out there who do spend 24/7 with the patient. We have prescribing pharmacists where we can utilise, and we spoke, and there was a good presentation yesterday about how life is really busy in the day of a doctor. So how can we relieve them of some of their workload? So there are things out there. So we have to be quite innovative about how we do things. So I think the bolder is preventing the patients coming in by providing a better service, and then also efficiently getting patients out, and that's about sharing the load.
Yeah. And once again, an interesting theme arising there, of picking up on what Robin was saying, of the way we're structured, the way we're set up, actually doesn't lend itself to blowing that boulder up, or it makes it harder to blow that boulder up. Yep, absolutely. Great, thank you. Robin, big boulder?
Look, it's really hard just to choose one thing, but
I am going to have to ask you to, though, just in terms of time.
If we do nothing else, we have to enable information flow between the hospital environment and the general practice environment. And so that means secure messaging, and I think it also means electronic referrals. And so it's not impossible to do. I think it'd be actually good to have a look at that slide. So we do an annual survey of GPs. Just this is not up here to point fingers at any hospital, okay? Because a lot of these results depend on how far advanced hospitals are with their electronic medical record and with their technology project. So, but it's just to illustrate the variability of how well or otherwise hospitals interact with GPs. So we do a survey annually of GPs around our own performance, but we ask them specific questions that are related to how well the service system is working and where we need to provide some assistance. And so the yellow boxes are, just trying to read it here, advising you of a patient's admission and treatment. The blue box is sharing clinical information. So there's a lot about, I haven't got the information I need for my patients. And I can also tell you that GPs would expect to receive this within 48 hours, but the reality is that the majority of these things will often take weeks to turn up in front of a GP, if at all. So, these are the sorts of things that we want to work with around and I do keep going back to discharge summaries. It's a simple first step. But one of those boxes, that green box, is about the treating team. And, at the end of the day, our objective is not just to transfer information, it's about shared care arrangements. So that word, being part of a team, is really important. And that's one of the things that as a PHN we're focusing on, is really promoting these shared care arrangements between the specialists and the GPs in the community, and making sure that the expertise of the specialists is accessible from the general practice at the time when it's needed. So please don't pass that information on to everybody and all and sundry, but it is really interesting to have a look at that and just see from a GP's perspective, we're just not getting what we need in general practice.
So Robin, once again, some structural and funding boulders there that separate us rather than bring us together. And also big technology issue, so wouldn't it be lovely to come back in 10 years and to have that looking completely differently, even if it's just off the back of improved technology? and what we're able to do with that. So we are really in a technology transition at the moment. Mind you, when I was at Medical Records School, which was about 150 years ago, they told us that the electronic medical record was just around the corner. Well, it's been a very big corner. That's all I can say. I think they said that just to keep us in the course, keep us excited. But it's been a very long path. Yes, so Diana, big boulders.
One thing.
Yep.
So if I'm allowed one thing.
Yeah, you
to
are.
get
You are for now.
Better, fair and equitable care, it would be moving away from paternalistic health care and using patients as an untapped resource and what adds value to them. And if you want to look at a model that they're really trying to work through this, it would be the realistic healthcare model that they're trying in NHS Scotland, where the Chief Medical Officer is really driving the message as the patient asks the question, why are they doing this to you? What happens if you don't have this done to you? What's the alternative? And what therefore would you like? If we give the problem back to the patients rather than think it's our problem to fix, I would suggest they'll fix it for us.
So, thank you for your brevity. I'm particularly interested in, once again, the structural barriers to real consumer participation. Now, I know Standard 2 has made a difference, national standards, because, it's kind of driven change that perhaps wouldn't have happened otherwise. And I know we've had consumer participation policies, certainly in Victoria, for a long, long time. But really, the pace of change is quite slow. Structurally, what would need to happen? You keep talking about paternalism, and it is a very deeply entrenched culture. Structurally or culturally, what boulder do you need to blow up so that we wake up one day and the consumer is an equal partner, the GP is an equal partner? Because at the moment, it's not quite the map we have in our heads.
Well, it's not one boulder, but as we have heard this morning from Cameron about distributed leadership, so we have to move away from we've got timeliness and qualityness, but actually we work along godliness. Yes. So if we can move away from godliness and actually educate people into getting the humanity back into healthcare and everybody's equal in this journey, then I think that's the starting point. Yeah.
My curiosity, and I'm kind of looking at the department, Better Safe Care Victoria people and all the people who pull the big levers. I'm very curious as to how we do that, because we really haven't made much of a dent. I know you'll be all thinking, but we do all these things with the consumers we never used to, and blah, 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 we do all this great stuff. I know. But basically, there's a lot of deeply entrenched barriers to seeing the consumer as a partner. And I just think it would be great to really sort of figure out what's at the bottom of that, because a lot of people don't want to change the structures. They don't want to change the power structures. They suit them perfectly well, So how do we find the why that's motivating and can bring everyone together around that? So that's kind of my real interest at the moment around all of this. So we've talked about some barriers and some boulders and why it's important. Are there any particular boulders that anyone in the audience would like that we haven't mentioned? Any big boulders to progress with timely care that you're just thinking, no one said this, I must say it now? Or someone said it, but I must reinforce it? Or do you think that gives a reasonably good picture? Oh, there's one here. Thank you. Please say who you are and where you're from.
Pauline Chapman from Ballarat. I think it's a really tough thing, but it's always money. And if I'd like to do it, I'd like to blow up that boulder that without cash we can't do stuff, because I think it is a double-edged sword. We do need to try and be fiscal with our budgets. But if we got more services, the support type services that were based more on helping people and making that service rather than trying to run a pelvic hospital as a business,
so
that'd be my big boulder that I'd like to blow up.
Shifting the focus, however we do that, and resources being one part of that. Yes. That and change.
Simon from St Vincent's. I think just following on from that theme of discussion, and I was jotting down some notes here before, and we've spoken about at St Vincent's about each patient receiving their care, the care that they want to receive, and we're quite protocol driven as a sector, and so immediately that's a shift away from that, and there's a continuum perhaps of individual care from you know, they're providing the best care we can for the patient once they're in a theatre or in a ward or in ED or in primary care. The other end of that continuum is defining and understanding and therefore providing the best care for a patient when they're at home, before they're in any setting whatsoever. And for me, and this goes to Robin's point, I think a little bit, who is that? Who's leading that work in terms of defining what the patient wants at a personal level when I'm at home with my family and kids? Where does that happen? Because individually, I think we're trying to do it, but what if all those individual bits are wrong when you add them up?
Yeah, no, absolutely.
Just a small question for someone to...
Yes. Is that a question? Or will I take it as a comment?
If someone's got an idea of who should be leading that, or if someone is...
But again, do we need a leader or do we need a conversation? So it's the distributed leadership that we should all be having a wellness day, a death day, where we actually talk about these things. We all live these lives and everyone thinks if they don't talk about death, then somehow it's not going to happen to them. But actually, surprise, surprise, it's going to happen to everyone in this room. So why have we not spoken about it with our families? Why do people not know whether someone is an organ donor or not? It's those sorts of conversations. And in the same way, the seatbelt legislation never changed the behaviour, but the conversations about seatbelt legislation changed the actual behaviour. So we've just got to start the conversations. However politically incorrect, you know, it's like the voluntary assisted dying, and we've got the people with the banners outside the Peter Mac. You know, it's now become politically incorrect to say, do you know what, lock those people up. They're not entitled to do that in my mind. You know, we've got to, oh yes, you know, we pussyfoot around it. We need people who are leading us, who actually are not afraid for someone to say, do you know what, I think you're completely wrong. Well, that's right, I don't care. I don't actually need you to agree with me, but I do need to be heard, and then I will hear you. But we can have different views, different opinions, but it should be out there. I should know which one of my children are happy to give an organ. If I don't, then it's a crime, I think. So
what you're talking about is so we talked about structural issues, and now we're talking about socialisation of change, and we've talked about that a little bit over the last couple of days. Yes, and I'll get to you in a minute. Thank you. It is becoming a much bigger thing now that you know, change. You have to have your formal structures for change, and you have to have your informal socialisation of change. And you know, things like smoking, drink driving. Yes, they're embedded in formal structures, but they actually became a thing through socialisation, the way people started to talk about it and what became acceptable and what didn't. They're very fascinating case studies, and they're the sorts of things I think we should study more when we're talking about how to change these really, really challenging structures and cultures that we have. Yes.
My name's Louise. I'm from Northeast Health Wangaratta. Background: 30 years of emergency nursing, some supervising.
Could you just hold the
supervising, and is that better? Yeah. And I've taken on a very exciting, challenging role of the acting nurse unit manager of the medical paediatric ward. I have a fairly good overview of the patient flow within the acute setting, and I think what we tend to overlook is nobody wants to be in hospital. People want to be home as soon as they can, and I don't think we listen to our patients enough and try and plan their discharges towards getting them home in a timely manner with supported services. There's complete confusion about, there's so many resources out there, but how to access them, what's the right pathway to access them for our patients. We're not listening to our patients, and I think what's coming through from a really interesting panel over there is our sharing of information is shocking. And I think, you know, being on the grassroots of patient care, you see how information is interpreted and assumption is made, and we're not listening to our patients enough. And I think that shared information is so vital. And how do we work towards a system that that shares information? Even accessing information from My Aged Care, you know, we have to have patient consent to access information. We can't, looking after acute patients, we don't know who their case manager is because we don't know where to find that information. And we'll ring up My Aged Care and they'll say, you know, we're not going to tell you, but the patient, we can tell the patient, but then how do you link all that information? And I just don't understand.
Yeah, well, big structural barriers, as we're saying, but that's a nice segue into where we're going now, which is what can we do? What are some of the innovations you're seeing? What are some of the things that give you hope? George, if I could ask you just to kick off, what if you had that? No, not if you had that episode of care. If your wife needed hospital care again, and I'm not suggesting that that's what we want for her, but if you did, describe even the first few hours. How would the first few hours look different if it was an ideal situation? So not the situation you had, but if you went back and if it was really good, what would it look like just even in the first few hours for you and your wife in the hospital?
I can't guarantee. So if the conditions can be improved, once we first arrive in the hospital ED, and the nurse come in to take full details and then to organize the bed for the patients. And for me as a care, it's much more relief in this condition. And also, if they can provide more opportunity for me to provide some information to the staff member, to the doctor, it would be much more appreciated. Because I know at this stage, a lot of people withdraw or delete their personal information from online because they think it's a private issue. However, if you are really in emergency situations, you can't talk, and if the hospital or service provider can access your personal information, is much more efficiency to provide the service for you.
Yep. So there's just it's not a lot to ask. George isn't asking us to reorganise the way we do things, yeah, which I think is really, really important. Yes, some structural changes would definitely. That's why I'm looking at Marie. That we really do need the big guns in on some cultural changes, which we can help make. But it doesn't take a lot to change something from ordinary to extraordinary, really, in the person-to-person interactions. So Jodie, big, hopeful, positive, proactive things that you can see?
Yeah. You sort of stole my thunder over there about sharing information. The time taken to get information of a patient who's presented previously at another hospital is a long time. And if it's after hours, it's a hell of a long time. I think moving to standardised shared platforms, like for example, the Parkville precinct is moving to Epic across 4 different hospitals to share information. I think that's exciting because that will cut down that time to appropriate care, especially at the front end. In ED, after hours, it's difficult to get information, but even on the wards, that turnaround time is quite long. So I think moving to these shared platforms such as Epic, for example, that's going to Parkville, I think that's a really positive move forward.
Yep. And of course, sharing information, the use of technology, which you're obviously talking about there, is fundamental. However, garbage in, garbage out still. So a lot depends on us making it work. Robin.
One big, bold thing that we're embarking upon in partnership with our hospitals is we're going to ban the fax by 2021. That's my target. 100% electronic referrals, no faxes. Now, I can't do that on my own, but my hospitals have set a date. We're serious about this.
I'm
got a
excited
date.
to hear it, believe me.
And that's our aim. 2 years, we're not using faxes for referrals in our catchment. So that's a big, bold thing.
Rock and roll.
I
yeah.
think the other thing which we really need to focus on, and my health record, we need to get to the point where there's a single source of truth around a patient's record. At the moment, our best hope is My Health Record, and I know that it's been extremely poorly rolled out by federal government. Nonetheless, it's our best chance. And so hospitals, GPs, allied health, all of us need to make a concerted effort to make better use or to even start using My Health Record, because until there's information on My Health Records of individual patients, nobody will pick them up and use them. And at the moment, it's all we've got. Even if we can get medications and test results on there, it's better than what we've got at the moment. So I think that's really important. But in terms of another big, bold thing, we know that in Australia we have a very fragmented service system, and that's due to our funding silos. We need to be co-investing at a regional basis between state, federal and local government. And this is another big, bold vision that we have in our catchment to secure that co-investment from all parties. Then we can plan regionally in terms of how we want to work as a service system, where services need to be located, and where to invest those dollars in community settings. And that will be a real step forward. So that's the other big, bold part of the vision for me.
Well, Robin, I will march with you in the streets with my Ban the Fax placard. Do you know, what must other, well, I know because sometimes you speak to them, what do you think other high-risk industries think of us when we're still talking about faxes? And interestingly, I submitted an article to a very well-known journal recently, and the fax field was mandatory. So I made it up. And I thought, this is legacy. This is really old-fashioned legacy. We've got to move on, people. Yeah, so great. Thank you. Yes,
yeah,
John.
I agree with what Robin said about My Health Record as being our biggest hope for giving the information to the patient and for us all then being able to use it. But the unintended consequence of the My Health Record is that no one's been educated or trained in writing a letter that's going to make the front page of the Bendigo Advertiser. We write letters, discharge summaries to other clinicians, and we write our diagnostic reports in the same way. So unless we at the same time focus on the softer skills and do human factor education into attitudes, beliefs, behaviours, cultures, teamwork, leadership, I think we're going to have a big problem on our hands. And where's the hope? Well, the hope is that there is more focus on general staff wellbeing in organisations. There is education programs, the non-technical skills that the surgeons are made to do. So they are at least talking the talk, even if not everyone's walking the walk. So I think that's my big boulder I'd like to overturn and move on that direction.
Yeah, thank you. Interestingly, I met one of the team responsible for registering people to My Health Record last week. Lovely, lovely guy. IT whiz, not from health. And he really, everything you just said about human factors, human change, socialising change, no. So isn't that interesting that that's who you put in charge of registering people for My Health Record? When there's so much opposition who are totally into all of that. You know, they've just played on the emotion they played every emotion string that they could find, and they've done it quite well. And the people for it, I think, and I was talking to him about it, and he still looked a bit bewildered, like, well, why isn't it great? Why don't people want to be a part of it? You know, yeah, fascinating, absolutely fascinating. Yep. Any comments about where we need to go? Yes, Jess, and one over here then. Yeah. Right, Jess first. Deb, sorry, Jess first. Yes. Speaking of death, just while Deb's bringing the mic over, if some of the people in this room are going to live until they're 132, you better get your act together because you don't want to be talking about this when you're 100, right? So we are passing the baton to you to sort this out for us.
They'll still be working at 100.
I'd like to say I'll let you know, but
yes, because they'll be looking after us. And I want this definitely sorted by the time you're looking after me.
So I'm Jess from St. Bees again, for people on the webinar. I want to touch on some of those points and just stress how important that is, because yesterday we talked a lot about the system. And in healthcare, the system is humans. We talk about it as this esoterical thing, but it's all made up of humans. One system that is not is IT infrastructure. And that makes the humans that create the healthcare system's job so much easier. And like you say, with the fax, the delays of residents spending, some residents just spend their day getting information via fax. Like, you've got to think about what kind of doctors we're training when some of their jobs are just to fax and get information so patients can be cared for. I know personally where I've had patients that have been complicated and I've needed to wait almost a day to get all the information across from their specialists and the different hospitals so that we don't have to repeat things, you know, and get all the accurate information, the test results, etc., so we can progress the care. So it's a huge cost. And I think that needs a system-wide, I might say, but a global approach. And it seems that if we've got some technologies that can integrate all of it, it makes sense to have one integrated platform. That's all I'm going to say.
Yes.
That level
and I
of
saw you
effort
thinking, no, I'm going to be
occurs.
kind to Kathy and stop there. So thank you, Jess.
All of that effort also happens in general practice. They spend hours chasing results, waiting on the phone, trying to talk to the right person. Such a waste.
Hi, I'm Keith Smith from Bowen Health. It's probably just observation, really. So I've got a paramedic background, but I'm from the project management office, and I've got a project background and worked in lots of different industries, from sort of mining, insurance, customer service. And I think probably there's an opportunity to learn from some of those other industries that do customer service really well. A few years ago, I sort of implemented a project across the general inquiries area, and best practice was based off other industries such as Qantas and Foxtel, around a mantra which was around first time issue resolution. And the key KPI in that general inquiries area was maximum of one handover. So if they can't resolve it, then it's one handover to the person who can resolve it. Coming back to some of the sort of presentations from yesterday and discussion today, sort of using that mantra when we talk about the number of handovers, putting the customer at the centre of the care, just probably thinking about it from the customer's point of view and the consumer and the patient point of view, is that KPI we should be following. So rather than sort of right care, right time, right place, sort of right care, first time, really.
Yep, thank you. Anyone want to make a comment on that?
It's interesting you mentioned about other industries. Probably the most profound education that I had when I managed Northern ED is how do we change our culture about how our staff accept our patients in the ambulances. And I went to a experience day with J.W. Marriott to see how the same thing, customer service, wanted to see how they actually did their customer service, because I wanted to bring some of them themes back. And just changing our use of language and turning it around to provide a service to the community was really important to get staff to step in the shoes of the community person, that is, in this case, getting the ambulances back on the road to service our community, because if that was your loved one, you'd want the ambulance there quicker. So changing the use of language and learning off other industries and how we provide that better customer service was really important in that space.
Yes, Jodie, interesting, isn't it? I mean, once upon a time I went and visited the airport and I spent the day with the ANSET customer service officer and patient safety officer. Blew my tiny little mind. And I was able to come back and implement about 0.1% of that. Not because it wasn't fabulous stuff, but because the will was not there. So we can learn from other industries. We should be. We've been talking about human factors now for 20 years and trying to learn from other high-risk industries. We've been talking about customers. I had my clerk's training customer service in 1990, right, from a very, very good person. Didn't make much difference. Why? Because in the end, no one's going to close you if you're not nice to the patients. And we talked about this yesterday. So the intrinsic motivation for us is huge, and it's hard. It's really, really hard. So I'm looking at all of you and all of you fabulous people and saying we really, you know, we need to do the Helen Bevan thing and start a bit of a movement around saying, you know, timely care, that's what we're talking about here today, but we're really talking about quality care in a broader sense, is going to be in the hands of all of the people in this room. And we've got to decide that these things are really important because they're not necessarily built into the way we run our health services. You know, we get a bit of patient satisfaction stuff when you rock up for your performance review, but it's really doesn't tell you very much, you know. So I guess, you know, from my perspective, something has to shift. And, you know, as we've been saying, I think on the panel, it really needs to come from all parts of the health system. So we need to go back and agitate a little bit and make this stuff important and look at the socialisation of change we've seen, such as seatbelts and drink driving and that sort of thing, and start working like that. Just to finish up, you've been absolutely fantastic. Thank you very much. Can you give one quick example of anything you've seen that's fantastic? And George, don't feel obliged to think of one if you can't, but if you can think of an example, George, where you've seen, you know, fantastic care, that would be great too. But I'll start with Diana. Any examples where you've gone, yes, if we could do more of that, that would be great. Anything to give us a little bit of hope and positivity to end on?
Well, yeah, I'll give you an example of something that we did about a week ago. So a lady came in to the emergency department and she'd got a very fast running heart rate, which was giving her some chest pain related to an infection she had on her leg. And we treated her infection in the ED and we slowed her heart rate down and she felt a whole lot better. And she was 88 and she had a son there and her daughter was coming the next day from Brisbane to visit her. So I discharged her under hospital in the home and she was out of the ED within about 3 hours. And I spoke to all the family and the daughter and the daughter who wasn't there, the family that were there and the patient. And I said, well, there's two options here. You can either come into hospital because you may well have had a little heart attack, but if you come into hospital and anything happens, it's likely that it won't be any different than if you're at home. And what would you like to do? Go home or stay in? She said, well, I'll go home. So she had actually had a non-STEMI, her troponin. We did a troponin every day and it rose steadily, but she was happily resting at home and getting her antibiotics. And she's, 10 days later alive and well. So we avoided a hospital admission through taking risk. But that risk was shared amongst the patient and the family, and everyone was aware of what we were doing, and there was a joint decision made. So I just would like to say, if we can have the people, again, as we've heard today, who are the senior clinical decision makers, who will then take the risk, front-loading that care, then I think we will avoid some of the problems of access.
Okay, thank you, Diana. Not an easy thing, complex, and that's what learning from other industries. Yes, I'm totally in agreement with it, but we do have some unique issues, and that calculated risk is a big part of our unique issues. Yes.
Is it my turn?
Yes, sorry, Robin.
Look,
yeah.
I actually think there's a lot of really hopeful things that are happening out there. There's all sorts of analytical tools now that we can apply to general practice data to proactively identify those clients at rising risk of an unplanned admission. That's fabulous. That means that we can get them back into their GP and start to address the issue rather than just waiting for something disastrous to happen. So that for me is really hopeful. The other thing is that I think there's a real appetite at the moment across the service sector to really do something quite significantly different around connected care and integrated care. You know, our hospital partners, our community health service partners and other community providers are already sitting around the table and looking at how we can, as a collective, as a system, manage a particular population cohort in a geographic region. How can we look at best use of our funds to manage that population and deliver services appropriately in the right place? And that's really exciting.
That is really exciting. Thank you for that. Jodie?
I'm going to talk about, because I've been involved in the last 2 years, with actually the patient flow partnerships through Better Care Victoria. So I think it's really important that we have a format or a forum for health services to get together and talk and share ideas. And I think it's important that, you know, areas like Better Care Victoria to actually facilitate that, because otherwise we really wouldn't do that well. And I know, just for example, from last year from Western Health and the year before from the Northern, we learned heaps from other organisations. And I think it's really good to form them networks and those learning experiences and sharing the ideas that everybody else has had. So I think that's really important.
And we love it, don't we? We love it when we get together and
It's
there's an
great.
excitement and an energy because we want it to be great.
Yeah, absolutely.
So more of that. Fantastic. George, is there any last comment you'd like to make?
In my view, health service is a people's business. Everyone involved. The positions can be changed, even can be swapped. Today, you're a service provider. You might be a doctor. You might be a nurse. But tomorrow, you might be a patient. You might be a care. You might be a family member. So I much appreciate the government's change of policy and invite the consumer be part of the service, and so we can share the information. As Robin said, I put the shoes in different positions. You can just feel.
Yeah. Thank you, George. Thank you very much for ending on such a lovely, positive note. I think you'll agree it's been a fabulous hour. And let's not forget, we do a lot of great stuff. What we're trying to do now is to go to the next level. And what I see is if we can get people excited about the next level, that's going to be the driving force. And then we can use technology to help us get there. So please join with me in thanking the panel. All right, got your bilbies. Thank you very much. All righty. We move on now to our final session, pre-lunch, which is from Better Care Victoria. And I have, thanks very much, Deb. Tristan Vasquez, Damon Grimwood, and Nat Bemrose. And they're going to talk about supporting timely care. So, Nat, I don't have anything to say about you, Nat. Perhaps you could talk just very briefly about, did you wander in off the street, or, you know, why it is that you're a part of this. Tristan is an industry coach on BCV's patient flow partnerships, where 15 health services from across the state focus on systemic improvements to access and flow, which many of you will be familiar with. And Damon is an industry coach supporting Better Care Victoria's Timely Care Partnership, and he just completed work on the 2018-2019 Patient Flow Partnership. So please welcome our Better Care Victoria colleagues.
Thank you. I'm Nat Bemrose. I'm actually the Manager of Improvement at Safer Care Victoria. I'm not a ring-in. Some of you will know me from some of the other improvement work that we have done. And I just didn't want to miss the opportunity to have a chat with you all today. And in the spirit of being responsive, we've actually tweaked our presentation slightly to take advantage of some of the conversations that we've been having and what we've been hearing. Timely care is huge priority for Timely care is a huge priority for Safer Care Victoria and the Better Care Victoria board. And we've been working, and these guys in the team have been working really, really hard with our health service partners to look at what we're currently doing and what we wish to do in the future with regard to patient flow and timely care. And we're currently in the final stages of approvals for our new partnerships. So we'll be using this opportunity to frame what we've learned and the objectives of what we'll be looking to deliver within our next partnership. But just to frame in the beginning what we've done previously, for those of you that may not be aware of some of the work that we've done, we started, I say we, as in Better Care Victoria, I'm fully aware that there's been a lot of work, improvement work being done in the timely care and patient flow space for many years, but we started our journey in 2016-17 with our Emergency Access Improvement Collaborative. We had 11 health services involved in that, mainly metros, and we recognised that, and the work that was done within that partnership, we then effectively spread to the next iteration of our partnership, which was in 2018, which was the Patient Flow Partnership. And thanks, Jodie, for giving some plug checks in the mail. This partnership had 15 health services across Victoria, including a couple of metros as well, and really worked to further embed some of the improvements that we had found and stuff that had worked in the first partnership and spreading those throughout Victoria as well. We also had an emergency access community of practice, which we had set up with the former partners of the Emergency Access Collaborative to keep the conversation going, very much what Jodie had mentioned before, keep the collaborative conversation going around what different services were doing and sharing what was working and their challenges and barriers and how we might overcome those. Now we're looking to support a new program in timely care, which will continue to drive improvement. And one of the main, I guess, take-home messages, and it goes back again to what Jodie had said about the work that we do in our improvement partnerships, is it really is that collaborative opportunity for people to come together, to learn from each other, and to help embed and sustain some of the improvements that they've done. And one of the other differences or the things that we bring to that is having our industry coaches to support those improvements and to support the individual health services that are involved in those as well. So I'll ask Damon to come up and just give us a reflective piece on what it is that, we've done this 3 times now. How can we take what we've learnt, and what are the objectives that we're looking to do in the future?
Rule number 1, always look at the screen, not the computer. So thanks, Nat. My job is just to really give you a bit of a reflection. I've only been part of the most recent Patient Flow Partnership, not the ones across, but I've heard stories. And we're going to talk a little bit just about the lessons we've learnt, because I figure if we invite George's, and we had a story about Joy yesterday, and most of us have heard patient stories, we probably owe it to them to reflect and make sure that we're doing the best we can. We always ask health services to reflect and make sure they're implementing best practice, so it's really incumbent on us. Now, I think if you'd stumbled into this room by accident yesterday and actually, sort of chosen to stay, heard all the presentations, there'd be nothing on that slide that's really a surprise to anyone, like what have been the challenges for sustainability and improvement over not just ours, but I imagine the experience in this room. So there's nothing really up there that I think anyone would be that amazed at. Is there anything there that anyone hasn't considered? Is there anything missing? I think there's one big thing missing. And we just talked about it quite a bit in that last session, is really the patient experience and how do we get that in there. Because often we tend to sort of focus inwards a little bit on what did we do, what could we have done better, but really the question has to be, and like the last 2 days have been really powerful, and it started with Shimon's talk, and it's been bookended by all the ones today right up to that panel session, that we need to work better at bringing the consumer a little bit front and centre. And a lot of these things we talk about, there's a lot of models around sustainability and things like that, but none of them really actually mention the consumer a little bit. So we need to work out a little bit of a better way to embed them. Like I say, I think we owe them to them. What we also owe as a supporting service, because we don't actually deliver care as Safer Care Victoria or Better Care Victoria, is what are the things that we are in the best position to influence, and what are the things that we're best in position to support you through influencing. So they're really the key lessons that we've had from the last few partnerships. And they're the kind of questions that we start to answer as we move towards designing the next one. So what do we hope? And this is where consumers are in. So there's two key parts in that. Really the top one is the one that we really want to get. We want to make sure that we improve patient experience, and one of the big challenges is how, like, I'm going to step back actually. I've had the privilege of listening to a bunch of patient stories over the last year, and it's always a privilege, and it always makes it really hard to stand up and talk after it, because it's the most powerful way of getting experience across. And we've heard Kathy mention mastery, joy, autonomy, mastery, purpose, which, you know, the Dan Pink sort of models of motivation and all these sort of things. And we get purpose in spades whenever we hear a consumer talk. The challenge is, how do we distill them to a KPI that matters to us? How do we get that experience? But also, how do we aggregate from the individual patient experience up to start to really understand the challenges of patient flow? So we need to work out a better way to do that. So these aren't necessarily sorted. The improvement on key metrics. So what are the key metrics? And I heard, I'm going to drop Cameron in it because he talked about a patient this morning at 3 hours and 59 minutes, it was good. So arguably the same patient 2 minutes later is bad, but you would argue the experience was the same, right? There's probably no outcome change or experience different for that patient that converts them from good to bad at 4 hours exactly. So we need to work out what are the metrics that matter, but how do, again, do we aggregate it up to make sure that we build the capacity in the system to deliver it for every patient, not just at the individual patient level. The things that we can really influence, we can promote the inter-service collaboration. So Jody yelled it out, Shimon yelled it out yesterday. It's been one of the things that I've really loved facilitating, is seeing all the services come together and do that collaboration. I think just watching them enjoy it is really powerful. So we need to work out a way we make sure we turbocharge that and we keep that front and centre of anything we offer. And the opportunities for capability development in any area where we can support. So we do have experts in that area, but similarly, we need to provide the space for you to be able to develop that capability, and that's one of the things we can do well. I guess when you're talking about the levers that we can pull, we can pull some of the funding levers that we can't necessarily, or we don't necessarily have to teach you how to do something, but we have to give you the space to be able to go and learn how to do something. So that were kind of the two slides that I wanted to present. I think Tristan's going to step up and talk about a little bit more about what's next.
Okay, thanks very much, everyone. What I wanted to do was a bit of a reflection piece, really. We are, as Nat has just said, we're in the midst of planning the next iteration of patient flow work. And we have learnt many lessons from the Emergency Department Collaborative and also from the Patient Flow Partnership that's just finished. And so what we'd like to do, we couldn't go past an opportunity of having all you wonderful people in this room without consulting with you and being able to reflect from your perspective, what is it that you would like? What is it that you desire from us at Better Care Victoria and Safer Care Victoria? It's too easy for us to get caught up in a little bubble, this project management or partnership bubble, and listen to a small group of people that we're in partnership with, working very intensely over the course of a long period of time, living their experiences and their problems and so on, and then expanding that towards the entire sector. So that's what we wanted to do. We wanted to reach out to you and see what you would like from us. Obviously, no promises that we can deliver on everything, every one of your desires, but really keen to touch base with what you think. So over to you. Can anyone start us off?
This is the interactive.
Yes. There are microphones
Okay,
around.
this is too good an opportunity to miss people, so don't miss it. If you really don't feel like speaking on the microphone, I know some people don't, jot something down on the pad on your table and leave it. Put For Safer Care Victoria at the top and jot it down, because it's a really great opportunity. But also we'd love to hear from some people as well.
I've got a horrible, Simon from St Vincent's again, I've got a horrible habit of talking too much, but no one else put their hand up, so I would. I was actually talking to Tiana from Werribee Mercy just in one of the breaks, and we were both talking about how we're working on things that could complement each other, and we reflected a little bit about that we don't know what we don't know, and we can talk about what best practice is and go out and seek best practice, but that's only in the context of when we know we're not at best practice. And so I think coming back to this question here about how can you support us, and I think goes back to Damon's point, is providing that structure and that forum that not forces us together, but facilitates us to come together and talk about what best practice is. And it opens our eyes. I think we're all very, very busy, and we've spoken the last couple of days about the demand on the system. In that context, sometimes we don't have a break to stop, take a step back, look sideways across the health sector and try and understand where are we doing good and where are we not doing good. And I think that this is maybe one of the opportunities that BCV has to provide for the sector.
Absolutely, and in fact, it's no surprise that you've gravitated towards Tiana. I observed, because I had the privilege of working with Tiana at Werribee Mercy, I observed that they actually received all of your medical staff from St Vincent's, and we had the very strange situation where they were very rigorous in their approach, they were very structured, they were very well behaved at St Vincent's. They were less so at Werribee Mercy. And we wondered on many occasions why the same people behave differently at these two different sites. And yet there hadn't been a cross-organisational approach to kind of looking at those behaviours and looking at those mechanisms. And I think that you're absolutely right in that observation that one of the ways that we can add value from Better Care Victoria, Safer Care Victoria's point of view is about creating that community of both practice but also of exchange amongst those of us that are interested in patient flow. I went into this job as a coach thinking that what I needed to do was carry some hard skills around, some technical skills around how to move patients from one section to another within the hospital. And in fact, I found really, really quickly that all that's been known for years and years. To your point, Kathy, you were talking about, being involved in this 20 years ago. And so when you look at the literature, we know what to do at a technical level. We've known for a long, long time. There's no shortage of papers. There's the Nuffield papers, there's the IHI white paper, there's lots of work out of Canada and other places in the US. We know what to do, and yet we don't seem to be doing it. So what are the interrupters? What are the barriers? What are the challenges? And I think that to that end, what I've seen over the course of the last year is that yes, we've had some exemplars, and I think St Vincent's are right up there in terms of patient flow and patient flow mechanisms. But there's also been a great deal of benefit from services just kind of talking to each other and propagating that desire to change and how to change. For me, one of my services that really excelled, and I don't think they're here today, is Southwest Healthcare, so Warrnambool. I think they saw themselves in a very different light. They were in awe of all the large metropolitan hospitals that were doing a great deal of work around patient flow. And then suddenly, out of nowhere, from their point of view, they've become a real leader in patient flow and daily operating systems and so on. So I think that did not come out of nowhere. That came out of the sharing and the contribution from working in a larger group. Anybody else? What can we do? What would you like from Better Care Victoria, Safer Care Victoria? Oh, a couple of hands up now. Thank you.
Oh, hi, Jess from Safe Ease again. Just to that point, I just want to bring it back to humans.
Yes.
Humans. This is a system. We can all come back on time for, after lunch, but if 5 of us decide all of a sudden we want to go to the toilet, that's our decision. Humans will do whatever they want in any given situation. So why things aren't working, understand the humans.
Yes.
I just can't stress that enough. What I would like to see is knowing how we're doing from a clinical care safety point of view. So we're not very good at knowing how our practices are doing. So where the evidence gives us some guidelines on what we should be doing as best practice, that, as a training clinician, we've got guidance on what we should be doing and recommending. But how is the hospital doing and performing on a larger level? So I was at the Thoracic Society conference last weekend, and one example which is perfect is bronchoscopies in the immunosuppressed febrile patient in hospital. And it's known that if you do it early, it's probably safer, but a matter of doing it later, it can increase the risk.
Yes.
Does it change management overall? Does it change the antibiotics that you give the patient? Does it change the outcome? Does each individual hospital service know how they're doing with that with their haematology patients or the immunosuppressed patients? I don't know. And I think that that's like being able to look at that is helpful to inform the practice, because the evidence only guides us and we're relying on, guidelines and etc. But how do we know that they're actually being validated?
Yes.
That would be helpful.
Yes, really good point. And we have heard that, in fact, that's one of the ways that the Health Roundtable can add value, but not all services are members of the Health Roundtable. So yes, absolutely, really good. I teach a lot of quality improvement to people that are generally naive in terms of how to approach quality improvement. And one of the observations that I always make is that health is already very complex, but it's also about human beings, the staff, providing services to other human beings who are the patients. And we know from the literature that, in fact, human beings are the greatest source of variance in any system. So, it's a perfect formula for lots and lots of variance. There was Jodie.
So there's just a comment, and I don't know what the answer is. So Mel Reid from Alfred Health. In terms of collaborating, I think, as we've said, we've collaborated around flow and access and systems for some time. One of the things that's coming up is around how do we empower our workforce, and how do we share, how do we have that same focus on engaging with our workforce in building compassion and building trust and relationships with patients, and how do we scale those initiatives as well? Because I think that's something we're all trying to do work on, but perhaps haven't had dedicated forums of that nature.
Yes, really good observation. Thank you for that. And in fact, over the course of the last year, as we delivered the Patient Flow Partnership, we had the very best intention of including the consumer voice, the patient experience. And we were able to do that through case studies. We were able to do that through consultation, but it was incredibly difficult to bring someone into the project groups at each of the health services. And in fact, we did not achieve that. We did manage to get the consumer voice at forums such as these that related to patient flow, but actually being an active participant in the change, we did not manage to do that. Now, I think that's for a couple of reasons. It's hard anyway to do, but it's particularly hard with patient flow because it's normally this invisible thing that patients can't quite get a sense of what it is. Yes, they can talk about satisfaction with their meals or their doctors or the information, their discharge, their medications and so on, but start a conversation around patient flow and often it's very difficult. And negating all of that is this idea of the patient being extremely thankful that they've been dealt with favourably, hopefully. Jodie.
Thanks. Jodie from the Royal Children's Hospital, day 4. So my point is that the Better Care Victoria has been very good at getting together collaboration in emergency departments. We've certainly learnt what works well, what doesn't work so well, which is a really good thing to discuss. my question is, have you considered extending that out to surgery, subacute, to make them connections for them key areas? When we talk about patient flow, they're obviously extremely key.
Yep, good question. Nat, you're probably better placed to answer that.
Can you all hear me? No, the people on the webinar.
That's a really good point, Jodie, and that's part of, I think, the design of what we're looking to do in the new timely care work is how we essentially run improvement across the whole continuum, the whole care continuum, so from front door through to exit. So part of the proposals really around having dedicated time for certain areas within that. So yes, still looking at the front door and ED and ambulance, but also looking at discharge and the intersection between as well. So that's something that the program will definitely look to achieve. And ideally, this program is something that won't necessarily have a foreseeable end date. It's something that we can continue to iterate as we go forward. That's a really big shift from what we've done previously, which is, you know, why we're in this state at the moment of getting our approvals, because our programs are built and iterated on what we've done previously. So as part of that is that they're very different. So we're really trying to use what we've learnt and the conversations that we've had to help inform the direction going forward.
So this is just a very a comment around bringing groups of people together. I think it's around the focus. So I think in terms of if the focus of the collaborative is around improving the patient experience, that it's around not necessarily just bringing people together around particular settings, but across that continuum. So I think it's important to bring people yeah, like I said, from across the continuum. But the other component around involving, just to your comment around patients and consumers and involving them in the discussion, ultimately patients go home when they feel safe to go home, and when we give them the resources to feel safe. So I think they are really, it's asking them what makes you feel safe, and what can we do to enable you to go home. And I think that voice, when you talk to those patients, as I think has been brought up before, they actually give you the answer. They, you know, so I think it is really important to foster that.
Oh, thank you. Andre Catrice, I'm from the Department of Health here in Victoria, in the Care for Older People unit. And I suppose a couple of observations. One probably goes to the comment there, is we spent a lot of time worrying about the front door and what might be in the community, and yet yesterday we saw a good presentation showing that the journey of a patient through the system within a ward, you know, 8 or 9 different care settings, 7 different teams. We talk about communication issues. Well, there we are, we've already created one. So how do we get a system where it gets the patient, a little bit like saying one hand only, and we get the person who actually needs definitive care, get that person to that point rather than up the circuitous, because we're all such specialists and we've all got our little bits. We tend to not look at the whole person, we're all looking at the sum of its parts. The other observation I think is workforce. I think it goes a little bit back to Mel's point. We've got to bring workforce people along with this.
Yes.
Everyone's talking about we're dealing with more and more complex people, and we're dealing with more and more complex situations. How do we keep workforce engaged in that? And I don't know if we give them the skills to do it. So how do we get people to understand, for instance, from my point of view, the older person often comes with a whole lot of issues, but yet within our training, undergraduate training, there's very little about older people in the broad concept. So not surprisingly, when they come into hospital, they see people as conditions and not essentially the whole person. And then how do we then get the workforce to actually understand, especially those key groups that often come in with the most complexity, often end up with are the most vulnerable and usually have the poorest outcomes. So we tend to think of nice pathways that work really well for things like trauma or, you know, discrete medical issues, but when people come in with a whole bunch of stuff, that becomes quite a different group. And yet I don't know if we deal with them in any different way to what we would do if they came in as any other simple conditions. So no wonder we end up with some obvious, quite complex and perverse difficulties in getting people through a system.
All right. Thanks very much, Andre. Just to finish off then, Kathy's point, if you didn't feel comfortable with speaking up, but you do want to communicate with us, we do have our contact details there, or by all means, scribble down some notes and pass them on to us. Thanks very much.
Thank you, Nat, Damon, and Tristan. That was a longish 15 minutes, but well worth it, I think, and a kind of a good way to tease out, once again, some of the key issues we've been talking about. So it is lunch, and if you could come back once again, as you have been so fabulous. Of course, Jess, no one's going to go rush off to the toilet when it's time to come back, because I've asked you very nicely not to. So if you can make your way back, start coming back about 1:25, we'll start bang on 1:30, and we shall get you away right on time today. Don't you worry, we've got a really interesting afternoon. So hang in there, people, and we'll see you after lunch. Thank you, everybody. Home stretch. Very important at this point, I think, because we've talked about a lot of problems and that can get a bit soul destroying. Never forget that if we didn't have all of you getting up every day doing what you do, the problems we talk about now would look like nothing in comparison to what we'd have. Yeah, so don't forget that. I just love health. I love it despite its frustrations because people like yourselves get up every day and do what you do. So don't forget to give yourself a little pat on the back. Yeah. And, you know, we choose to work in a complex system and therefore there are a lot of problems and a lot of challenges. But it certainly keeps us alive and interested and using our noggins to try and do things better and better. So let's get on the home stretch now. Get some great examples of fantastic work. And don't forget to jot down what you can take back, what you'd like to take back. If you've still got some space on your note sheets, very, very important. All right, everyone turn to the person next to you and say, "We're still here." Okay, thank you. Thank you. So it's my pleasure to introduce Kate Wyman, who's a physio and has been in hospital management for the last 10 years. 10 years, nothing. She's passionate about a whole of hospital approach to timely and quality care. She currently works at Monash Health and is responsible for emergency services, general medicine and subacute services, as well as the Monash Medical Centre and Kingston Centre sites. Please welcome Kate to talk about real-time care accommodation placement Port of Four hospitals. Yay!
Thanks, Kathy. Thank you. So Harry and I were just comparing who we think's got the tougher gig for this afternoon, me after lunch or him as the closing act. But what we've committed to is to make it as entertaining, powerful, and I suppose, as Kathy says, some ideas for you to take back today. So my name's Kate, as Kathy said, and happy to talk to you today about the Monash Health experience using our real-time data and visualisation. And I understand what you've had from a few of the people at lunch. You've talked a lot about waiting for what and progression of care and timely progression of care, be that through emergency departments, inpatients, subacute inpatients. So hopefully what I can bring to you today is some of the ways that we've started looking at that and how we use some of our systems to assist our clinicians with their decision making. So I'll tell you a little bit about Monash Health. The business analytics, so just to give you a bit of background and a bit of theory around business analytics and data, that might be helpful. But I think what you want to, and what I want to take you through is just some of our dashboards and our scenarios. So as I said to you, at the emergency department, capacity analysis, how we use our daily operating rhythm together with our waiting for what and our patient flow dashboards. But also dashboards plus people equals flow. So you can't actually just sit and look at them. Obviously, it's about bringing people to action and how we do that and how we've done that at Monash Health. Of course, you want to know that I've got credibility to come and speak to you about this. So has there been any improvements associated with implementation of these things at Monash Health? Hopefully, I'll be able to demonstrate that there has been. And I'm sure you might want to know, can I have a live dashboard too? And so, as Kathy said, taking stuff back to your health services around that will be a critical. Whilst I'm not an expert technically, I think I can help you answer that question, and then we'll have some time for questions. What I've also said is some of the dashboards you might want to ask me about and at the time, so I'm happy to take questions. So please don't be shy when we're going through those scenarios. So hopefully that's what you're expecting, because that's what I'm here to talk about. Monash Health, we have, these are all our large sort of campuses. We've actually got 45 sites. In the navy blue there are the major hospital sites. We're down the southeast corridor of Melbourne. We see upwards of 240,000 ED presentations every year to our 3 EDs. We were lucky enough to have 305 people turn up on Saturday to Monash Medical Centre Clayton, to one emergency department in one 24-hour period. So I suspect that number's going up somewhat, and I'm sure that's some of the challenges you're also experiencing in your health services. So normally we have about 245 as an average day at Clayton. We got 305, so those numbers are going up. And we see about 650 in total across the 3 EDs. We've got 745 adult inpatient beds across all our hospitals, 1,500 in total if you add in subacute and our children's hospital as well. So that's a bit about our context. So data in health. Does anybody know what this is? Has anybody seen that before? No? Do they know who created that? No? So that's some of the first data in health. And so Florence Nightingale is actually responsible for that breakout chart that you see down there. 1836 was when she put that together. It's an analysis of the mortality in the army I think in the UK. And you can see that that's the first sort of pie chart sort of breakout analysis that she's done. If we shoot through over time, obviously, particularly from the 1970s onwards, we've seen a proliferation of computing, we've seen proliferation of email, connecting our departments. So, you know, departments used to very much work separately. We're connecting up our hospital departments. They're all starting to talk to each other variously. And we've got bedside clinical applications. And now in 2019, in that top right-hand corner, is some live monitoring and predictive data. So that's one of our dashboards. That's actually yesterday what happened. And you can see the Monash Health catchment, where the people actually came from. So this is actually where our patients presented from, what they presented with, that's abdo pain there, what categories they were, how many ambulances came per hour, and then presentations per hour. So that's how data in health has changed over that period in time. So where are you? So where are you in your health service in essentially this framework, which talks about the value, the business value, so the added value that the data makes to your business or to your health service, and the complexity of that. So as you can see, it moves from reporting through to analysis. So why did it happen? Moves away from what happened to why did it happen, what's happening now, and what might happen. And then obviously as you move further out into the predictive analysis and the scorecards, you get actually much more power and added value in terms of the health service. I'd really like to know, in terms of who is in the audience, whereabouts your health service is. So is anybody happy to volunteer where you think you might be? Go, tell me.
We're in between reporting and analysis.
Right. Right, that would be PAPS down here. Okay, what happened? Yeah, excellent. So that's excellent. So we've would most people say they would feel they're perhaps in the analysis of why did it happen? So maybe day, apart from Echuca, but what happened the day before? Yeah? Because otherwise it just gives me a sense of what to talk you through. You were monitoring? Yeah. Okay, what's happening now? Excellent. So you might be able to relate. So in essence, I suppose what we were looking for at Monash Health was to move from our data and the what's happened and our analytics to what's happening now and how we would bring the software to life. So how would our clinicians start to engage with what's happening now and some of the predictive analytics to make decisions about what to do next. And you want to do that without reinventing the wheel. These are two particular software tools. You may be familiar. I can see some people nodding. Microsoft Power BI, and that's what Monash Health uses. That's one of the products, and Tableau's the other one. You can see they're both up in terms of the leaders in this field, but you can also see that this software exists. And the software exists to essentially bring the data to life so that people can engage, they can see really easily trends or outliers or anomalies so that they can adjust and understand what's happening now. And so those are the two main ones, and I think perhaps some of you would have heard of those. Reasonably cost effective, and I'll encourage you to have a look at YouTube. You can see Power BI, how-tos are reasonably cheap and simple to get started. So where are we? In terms of Monash Health, we feel we're moving from the monitoring, what's happening now, through to the predictive analytics. And I'm going to use some of the dashboards to take you through how we've started to go from what's happening now and to what might happen. And obviously for you in the audience, it's about how do we get to that point of what's happening now. So that's the ED capacity dashboard. So that's live. In my handbag down there, I've got tablet and an iPhone that can give me this view, can tell me what's happening in any 3 of the emergency departments. This is actually a view for, I think it was KCED. You'll note that I've selected a particularly good day, as you would expect me to do as the General Manager of Emergency Services. So this was a great day here, and this was actually KC Hospital last week. And so what I thought might be helpful is some of the things that we use. So we can see if there's a surge. So the number of people that arrived, and I know that in the background we're monitoring this actively in terms of the Department of Health as well as locally, but these are major. This is one thing that tells me exactly how many people have arrived in the last hour, and I know that the limit for fifth is 20 at Clayton. If I know there's more than 20, there's something, certainly in that hour to adjust to, and certainly 8's a fairly average day at Casey. So I can also see is that number of non-admitted patients moves across. So what is going to happen is that clinical decision making is going to occur, bed requests are going to go on, or patients will be discharged. So you can see the timeliness of which your ED is operating. Very critical is obviously understanding a single source of truth about how many ambulances are in the emergency department right now and are due for an offload. So we can respond there. You can see that one is between 10 and 20 minutes off our system. And so that certainly gives us and the team obviously they're working off back end of Symphony currently, but that will give you a certain understanding, I suppose, of what's happening in the ambulances, and certainly particularly in times of surge, how many there. The acuity in the department is really important to understand. So you can see this at a glance. So those are the category numbers, and you can see how many category patients are waiting to be seen by a clinician there. So that's a really good understanding of the acuity in the department. And the current ED patients, so that gives you an idea of where there's capacity. So there's short stay capacity. So the ED director, who uses these dashboards just as readily as I do, can make some decisions about how she is, or he, is actually deploying the staff and decision making. So to her, she would, or him in this instance, would talk to the main cubicle's doctors. Is there any patients for short stay? Let's prioritise doing that. We've got capacity there. I mean, and obviously as you get to know locally the systems around that. The numbers of admissions, and just in terms of the context from a whole of hospital perspective, you can see how many patients are waiting beds in the hospital. So in terms of responding to that ambulance that's waiting for offload, there's actually 2 patients there that are ready to leave the department up to the hospital beds, so within the next 15-30 minutes. So we know we can create capacity in that way if there was another capacity in the ED. Did anybody want to ask any questions about that? That one's fairly, I think it's quite a helpful one. The patient flow one I know is where you've had a lot of conversation today. Oh, yep.
Sorry, just Belinda from Alfred Health.
Hello.
Do you have a separate AV arrivals board, or does that somehow link into these dashboards?
So the AV arrivals board is separate, and we use those visual management in the EDs as well. What we know is that the AV have got to offload on their system. We can see when we've offloaded in Symphony around that, and that particularly that that's set up around our 40-minute KPI here. We use both. The AV arrivals board is really helpful what's incoming and when it is offloaded, but this one can give us a single source of truth to talk to the group manager about what's occurring and what's a hospital delay. So patient flow dashboard, this is a single snapshot of how many beds essentially in the hospital. So this is Monash Medical Centre Clayton, 44 open beds. And this is the kind of critical number that I look at every day. And as I'm taking, as a general manager, taking decisions about capacity in the hospital overall. So that number, this is where we're starting to introduce the what's happening now and the predictive analysis. So that 30 is that number of 30 is the number of patients we're still expecting to have bed requests come through the ED based on an average day. So we can see at midnight that minus 16 is the number of patients that would be in the ED awaiting an inpatient bed. Does that make sense? So obviously, if I've got additional capacity that I can open, or there's opportunities, I suppose, around any flexible capacity, the decision today, if that was that dashboard, would be to open them so that the ED has actually got, reduced number of inpatients in it. What you can also see across the course of the day, so this is, I think I took this snapshot about 2 p.m. You can see where there's a gap in the discharges, and the number of discharges, the number of patients admitted. So I'm sure in terms of flow, there's a number of people who work in flow access roles in the audience. So you can start to understand if you've got actually unallocated beds within the hospital and an opportunity to connect people up in terms of communication. You can drill down here into wards. Where the vacant wards are, where the vacant beds are, etc. In terms of the waiting for what, and I know this has been a theme. Oh gosh, that's a tremulous moment for the presenter. So in our waiting for what, we use Patient Flow Manager on the wards. Do a number of, how many people in here use Patient Flow Manager? Yeah, so about half. So this is on the wards, this is the clinical teams complete, estimated discharge dates, what the patients are waiting for. So we've created a waiting for what part in our patient flow dashboard and patient flow manager, and then this dashboard sits on top of that to give us any number of views. Of what patients are waiting for. So in this, you can see that there are 9 patients who are waiting for an imaging scan or result ahead in the day that we're looking at. And that the imaging manager can pull a report off, because we've got patient level data in here, so he can pull a patient level report of those patients that are waiting for imaging and therefore prioritise them. This is about progression of care. It's not necessarily about okay. Gosh. I don't know whether it is. It's got tape around it and everything. I'm not sure, but excellent. All right, sorry, I'll try to stop then. So in terms of what patients are waiting for, there's visibility. I'm going to put it down. Yeah, it could be user error. That's much more likely. So then what we can see at any point is what patients are waiting for. It's all right, don't worry. So in this case, what we can do is select out of these reports and off this dashboard of what patients are waiting for. Echoes seem to be one that comes up in a few health, in a few of the health environments. So I can pull a report that tells me how many patients are waiting at any one time for an echo to progress their care in an inpatient setting. And from that point of view, then what I get is a trended report, which was those red lines up there, and into what I can also see in that trend is that the number of patients waiting per day for an echo to progress their care is reducing. So our timeliness of our process there for getting people into echo might be improving. I mean, it's not a definitive thing, but essentially you can get a sense of whether it's working, whether there are further delays to care, and what we can do is select any one of those things: allied health, physiotherapy, imaging, theatre, that's another one up there, you know, our pharmacy, our scripts, etc. So, and you can select for, as you can see, confirmed discharges. So if you've got confirmed discharges in the day, can you bring them further forward if there's the test? We can select for pending discharges as well. And one of the other features that this dashboard allows you to do is to work through the estimated date of discharge. So you can actually select for Monday, you could select, you know, an estimated date of discharge in 3 days' time, which means you can do some predictive staffing around what numbers of imaging requests, where you also, I mean, it would be great if we could do that Saturdays and Sundays. That would even be better, but you can certainly see readily the delays associated with progressing care over the weekend. Whilst we're fixing that, did anybody have any questions about that? Are people using this type of dashboard? I'll go.
Hi, Leanne from Austin Health. Just the information on where people are, what they're waiting for, like in your imaging here, and you've got echo. How does that where's that information pulled from?
So that's the clinicians are putting that into the patient flow dashboard. Yes, sorry, the patient flow manager system, which has journey boards up in the wards. So it's pulling off that, and the completion down at the bottom, the yellow 83%, is that's how many patients have had that completed by the treating team. So it tells you whether you've got an accurate, you know, completion rate for a start. So that's where it comes from.
Shane, one of the registrars in the ED at the Alfred. Just on the back of that question, the data is only as good as the people putting in the data. So what's your compliance like with people inputting data? Because, you know, all the medical staff, nursing staff are already busy.
Yes.
How do you check your accuracy of your data?
Yes, great question. And I think that's where I get to, you've got people and data. That's where you get your success. 83% I'd say is fairly low. That's later in the day. 8 a.m, this is, you know, all help. Each of our sites have this upwards of 90%, so in completion. I think we've still got some work to do around the estimated date of discharge, and I think for some inpatient areas that's easier than others, but that's a key piece of work that we're talking about weekly with our teams. So absolutely, I think if people can start to see the data being used and they can see it helping, so if they can see progression of care or what's waiting, then they start to use it more. The other things that this resolves is I thought I'd referred them, but I didn't. So imaging would quite rightly say 9 of these people, 5 of them I don't have referrals for. And I say, great, let's resolve that and get the referral in. So it sort of prompts that. On-call scenarios, and I think I won't dwell on this too long, but we've got a whole dashboard for a whole of health service scenario. So in one dashboard, you can see all of your available capacities. So particularly out of hours, their ability to see what's happening in the health service or on one of your sites is able. But as the question was here at the back, the dashboards plus people equals flow. So we have these dashboards available on our iPhones, on our iPads, we have them on televisions, we have them, we have a number of them. We have an elective surgery one, we have hospital trends, we've got trended data, we've got maternity data, we've got quality and safety data. So the ideas and the opportunities are limitless, and there's a couple of key kind of successes that enable those. This particularly relaxed, unposed view of the emergency department, I was like, act natural, and that's as good as they could do. But essentially, you know, it is about the people, and I wanted to kind of prove to you that these are live and they are being used in scenarios, and not particularly convincing photo, but that was the best I could do. And you'll see my credibility here as one of the top users of the system. And I think what you can see there, though, is there's a lot of people using this, and I'll show you some trended data at otherwise. What we've done, and where the success is coming as well, is we have, as a number of you already have heard of, have daily operating rhythms. So now we have our people and standard work in terms of what our people are doing and how they're coming together daily and routinely to discuss access flow, quality issues, any safety issues, code issues. But we've now got our dashboards and we're live, so we're working in the now and with our predictive analytics to make those decisions much more confidently. Oh, now the computer's not working. I'll try the clicker. Yay! So is this working? I think there's, and it goes to my answer before, people are starting to use the system. So the usage you can see there is trending up, and that trend is continuing. So I think there's nothing that proves that it's more useful than the more people that are using it. So build it and they will come, and they have kept coming and they keep using it. So I think one of the keys, is it working, is that. But of course, we're all about our patients, and you can see that they are staying for shorter periods of time in the health service. So those are our three main inpatient sites: Clayton, Casey and Dandenong. And those arrows are pointing to the overlay of the dashboards and the operating rhythm, and essentially the reduction in the length of stay. And I think goes to the waiting for what conversation that I was talking about progression of care particularly. We've got a little bit of a way to go to link that up to the emergency department performance, but you can see that the lengths of stay in our EDs are starting to come down significantly over that same time period. And that's about the occupancy, reduced occupancy in the ED, allowing flow, but it's in the context of those numbers I gave you up the front in terms of 300 people coming at once is a little bit challenging to deal with, but we're certainly seeing significant improvements in our ED flow as well. So the critical question, can I have a live dashboard too? So the technical parts of what Monash Health has done has been, and of course this isn't information that I didn't find out other than going to our Director of Business Intelligence, but over 5 years, Monash Health has built a data warehouse which has enabled a single source of truth, if you like. In that warehouse we have cubes, we've got enterprise data warehouse. I don't actually know what that all means. Essentially, those left-hand systems are what you're more familiar with. So Symphony is an ED system, FirstNet, IPM, our HR systems, our RiskMan, so any of our quality data, and then is also housed in a central warehouse of which we've got cubes that come off. And there's a number of opportunities here in terms of performance reports, interactive dashboards, which I've just talked to you about, but it also comes in various forms and information delivery. So what we've worked to make sure is we're interactive as well as the push-pull effect of our reports. But I think sometimes this type of framework, which I think the team in the business intelligence have done an amazing job, and it started prior to, certainly myself being at Monash Health. But I asked this very question on behalf of you all. Can you have a dashboard? And the answer was yes. In fact, you can have a dashboard off an Excel spreadsheet, essentially. So the visual data, the visualization of your data, the meaningful way it's presented, the ways that you can do that can all be done with a very minimal outlay for a Power BI software pack. I mean, that's the one I know. Obviously, there's a couple other choices in the market, but that can actually happen. And it can happen off the back of those systems, so IPM or a Symphony or a patient flow manager. So, I think it's a bit about what I would say is it's about how you ask the question of your business intelligence folks. Folks, that's not a great word, but treat them as friends. They'll come back and. But in essence, and I was kind of thinking about this as well, is that often they are striving for the perfection. They're striving for the central source of truth, and rightly they should do. But as I've shown you, that's a 2 to 3 year project that's underway, etc. But you can essentially have it off your live system. You can have it off your live systems now. So he was very clear that you could have that dashboards off the top. So if you don't have a data warehouse and you don't have all of those other infrastructures, there is the opportunity still to use this software. And certainly I'm happy to, on behalf of Monash Health, offer opportunity through myself to ask any questions that you would have of that. What did we learn? Well, you need to add value. I think our utilisation shows that we're adding value. You have to, goes counter to slightly to the point I just made. A single source of truth does help. It does stop people blaming the data, but within, don't strive for perfection in the absence of progress or the ability to see what you're doing in real time. Develop them with your clinicians. So, the ED one was up to about version 8 because when you involve ED directors and ED nurse managers, you tend to get a varying number of opinion. I've got 6 of those people. So we kind of got to a point where we were all happy managing the business. And obviously the staff actually want to know what's happening now, and they certainly want to know what's likely to happen and how they can help you make decisions to progress the care of our patients.
Thank you very much, Kate. Obviously, you took some questions during your presentation, but does anyone have anything else or any comments that you'd like to make? Yes, one quick one down there. Thanks, Deb.
Thank you, that was really informative. I'm just curious about knowing that catchment area is one of increased population and how you're working with predictive data to prepare for the long term.
Great question. So the growth in the Casey corridor, I think, and there's some people that might have that I think if not the highest in the state, it's pretty close to being the highest sort of growth down that corridor. We work off the same as any other health services in terms of how we plan and do our strategic planning for capacity down there. So I can't really tell you that these are the dashboards that are helping us with that, but we obviously have the same data sources that we share with other health services around predicted demand. But I think we would acknowledge that perhaps that corridor has certainly grown a lot quicker than we have. We're opening Casey Hospital in terms of that's being commissioned later this year, and that's got a big tower there, but that's certainly looking to address that demand down there. No worries.
Anyone else? All right. We've got one quick one. Yes, you can have
Oh.
one.
Really?
Oh.
Claire's from Monash Health,
Yeah.
so this
I
is
can tell why you
this is the one that's going to get me.
No, it's not going to get you, Kate. I work in a role as a director of clinical operations in elective surgery. So in some ways, Kate and I are natural-born enemies because she's emergency and I'm surgery. So what some of this data has done, we've developed recently an elective bookings report. So we can look predictively what's coming up across the organisation for the next 2 weeks.
Yeah.
And so we can have conversations with, you can drill down to site, ward, specialty, day case, multi-day. In its first iteration, we're just looking at the planned length of stay, so we can work out whether our plans are worth the paper they're written on or not. And then we can go back to clinicians and start working. So the data does work for everybody if you work together. So I was surprised because I was asked to build an Excel spreadsheet and I thought, I can't do that again for bed bookings. And the head of BI took him a couple of days and we had a report.
Absolutely.
So it was great.
Yeah. That's a great contribution from Claire there. So it's actually then not just about our emergency demand. We can overlay our elective demand and then we can make collective decisions because we're not enemies. We're all a whole of health service. So, but we can make decisions so that all patients can access care in a timely way. So yeah, it's a good point.
All right.
Lovely. Thank you.
Join with me in thanking Kate very
much.
Oh,
wow. Thank you. Thank you. My Twitter handle and LinkedIn are up there, so on the front, so you're more than welcome to contact me or via email at Monash Health.
Thanks, Kate. Thank you very much. Yeah, nice note to end on there. Shared understanding. Yeah, like Homer and Lisa yesterday talking about pie, Shared understanding can get us an awfully long way, and it's definitely a big theme of these 2 days. Quick quiz, what else did Florence Nightingale give us, apart from being possibly the first quality manager? And we've been talking about it all day, really. She gave us a military model of hospitals, which is part of our problem. Very top-down, very hierarchical, very orders and obedience based. And you can see the merit in it, you know, I'm not knocking it, but there's some barriers to doing the sorts of things we need to do working across as well. So amazing, amazing, amazing person, but perhaps that model is starting to outlive its usefulness. Alrighty, so we're now going to hear from Daily Care, and we're going to hear from Tal Roseby and Alex Lynch. So Tal's story is that following a difficult family experience trying to find care for his grandparents in 2012, Tal began to question the processes and provision of aged care in Australia. His research into care across Australia revealed that the general consumer had no certainty in finding the best aged care solution for a family member or loved one, and that no integrated care solution existed in the marketplace. We could have saved you a lot of trouble, Tal, if you just asked us. No research required. So Daily Care was born, and Tal's going to talk to us about that. And Alex Lynch has headed up the launch of more than 10 publisher brands, building a reputation for fast-to-market innovation. Alex joined Daily Care following her role as a commercial director for Domain Vic, and combines her experience in consumer, digital and content environments with her long-standing drive to develop lasting social change. Please welcome Tal and Alex.
Thank you very much for inviting us to talk. I'd just like to say at the outset that Alex and I are not from any government agency. We're not from any health services, like all of you great people, so please be gentle with us. So I just wanted to give you a bit of an insight into our journey here today. So approximately 2 years ago, we were really fortunate to be a part of to be a partner really with Royal Melbourne Hospital when they had their inaugural Health Tech Accelerator. We were one of 10 organisations that effectively spent 3 months in the hospital, but we were really the only ones with an aged care lens on. We were tasked with making the journey from hospital to residential aged care smoother and faster using human-centred design. So what does all that mean? We thought, well, this shouldn't be terribly hard, but what we discovered was that we actually needed to satisfy 3 different audiences. Today, we're going to take you through the hospital view of the world, but effectively, we needed to satisfy the hospitals, aged care facilities, and of course, without question, all the families who are generally very scared, emotional, and confused about the process of actually moving into residential aged care for the first time. So at the time that we had at Royal Melbourne Hospital, we effectively mapped out all of the current processes that have been used for many years, and we were very lucky because we had access to social workers, the head of geriatrics, up to the COO, and we basically said to them, you know, what's the biggest problem that you face in trying to give families the right information about residential aged care? And they kept saying, well, you know, Royal Melbourne as an example, we've got about 100 facilities within our catchment area. That means we get 100 vacancy lists emailed, knocks on doors. We talked about faxes before, so faxes is definitely one as well. And of course, all of those data points were very different and very hard for anybody to decipher. So if we said to them, if we could build something from scratch for you, what would that look like? And we did, and we'll show you that today. And then we went out and spent the next 3 months with residential aged care facilities as well. And we spoke to the big national providers, the non-for-profits, faith-based, single operators, all the way to SRSs, and asked them what their problems were. And they said, well, we try and get in contact with the hospitals. They don't have time to see us. We've got these new offerings, but we don't know how to get in contact with them. We send all these emails, but we don't even know if they're getting opened. And so we said, if we could build something from scratch for you, what would that look like? And so we did. So really, why are we doing this? I mean, one of the things in our journey, one of the things that we found was, and what we uncovered, which we didn't know, being not from health, is there's approximately 310,000 bed days waiting for residential aged care placement nationally. That was the 2017-18 report, up from about 264,000 a couple of years prior to that, assuming that it'll probably go up again. So that must mean that patient flow and timely care would be hugely affected if we could help in the process of assisting social workers in a very short time frame to be able to find live, real-time vacancies that are care appropriate, culturally appropriate, geographically appropriate. And by the way, Alex and I have been very busy. We've been up and down the east coast of Australia. We've spoken to Queensland hospitals, New South Wales hospitals, and effectively the themes are the same coming through. So Alex and I agreed in collaboration with the hospitals that we needed to have a purpose and an impact in the following ways. So social workers should be able to do their job by caring for patients and not necessarily spending countless hours playing phone tag trying to find vacancies. That they shouldn't just be finding vacancies, but also care appropriate vacancies. That residential aged care facilities should be able to advise hospitals when they have a vacancy in real time. And the residential aged care providers should be able to improve their offering to match what is happening in the hospital's catchment areas. So we did a pilot with Royal Melbourne a year after the Health Tech Accelerator, and we measured between 2017, the same time frame, to 2018, using our system and not using our system, and effectively we saved them 44% improvement of days. What they were able to do was also get a short list, in other words, care appropriate vacancies in 3 minutes. And so what we're going to do now is we're actually just going to show you a little bit about the platform so you can actually see that in real time. Alex.
Hi. Right. Okay. And we're up. Thank you. So this is Daily Connect. Daily Connect, to Tel's point, has been the result of many hours of work, hundreds of meetings with residential aged care providers. Ideally, we would like to one day extend this to... Oh yeah, that thing. Okay. Ideally, we'd like to see this portal extend beyond residential aged care to be able to help admissions ED-wise, say with home care or the likes of NDIS providers. At this point, it is residential care, and I'll just give you a really quick run through of its functions. So, over here. Right, so there might be a moment. Right. Okay. So what you're seeing here is the social worker's view or the nurse unit manager's view or whoever, and we do have quite a number of different roles within hospitals that are currently using it, using this interface. So as with any search portal, we've really tried to make it as simple as possible, and literally it's just a matter of either plugging in a postcode or a suburb and then being able to search beyond that. As you'll see up here, we have not just permanent care, but say, for example, for ED departments, you could search just solely for emergency or dementia secure, as an example, respite care. So for the sake of today's demonstration, we'll just quickly run through the permanent care. So if you were to search in Parkville, as an example, you could radius out from 2 kilometres right up to 500 kilometres if it was a very, very specific care concern that you're after. For the most part, the hospitals that we have on board, being Monash Health, interestingly enough, Royal Melbourne, Western Health, Northern Health, Epworth, and a few of the Healthscope hospitals, their mean radius is around about 10 kilometres. Then where we've invested heavily in terms of the patient-centric nature of this portal is to be able to put in additional filters, and filters primarily that certainly the most valuable filters that you can't find anywhere else other than picking up the phone call to a provider and asking them in that moment. So of these filters, you can use any or none of them when you're searching to make up a shortlist for residential aged care vacancies. One such example, obviously we've got gender in there when we're looking at shared spaces or shared rooms, but one such example is a cultural facility. We know that cultural facilities or specific cultural facilities largely have longer wait lists. So what we've done is we've asked providers where they've got an organic group of residents that perhaps belong to a particular culture. We've also extended that, which we'll be rolling out through this portal, where they can find certain staff languages, where there's a strong community of LGBTI residents, war veterans and widowers, and we're also extending it to under 65-year-old peer groups within residential aged care facilities, as we know that is certainly a growing area. We will also be extending these filters to be able to identify for social workers to be able to search by where an aged care provider is also an NDIS provider, so they're more well acquainted with that process, because we know that can be lengthy, or where the patient also has NDIS funding but has been assessed for aged care, so the provider will know that they will have to work with the NDIS case manager as well, having them on site. Then moving across to care needs, and this is where the vacancies actually sit. So up here you'll see the top three, and we're just about to include high care integrated dementia, is where a provider will literally presses a plus or minus button and can change in real time the number of vacancies they have attached to these particular care types, if it's not just general permanent care, in which case you wouldn't select any. What we are finding is obviously secure dementia is in great demand. Look, we're finding a lot happening in the high care integrated space that can certainly be surfaced through this portal. Then at a facility level, the perhaps more complex care needs that are specific to patients who have been assessed for care, we've sort of bucketed in at a facility level. So example of those is challenging behaviours, obviously where they've got hallways that can take wheelchairs, peg feeds. Oh, hello. Peg feeds are another that are in great demand. And what a lot of the hospitals have said to us when they're looking at the catchment is, with those types of things, if we find that a lot of providers don't have the skills, we're willing to offer training. So we can certainly assess it through this portal. Then just quickly moving on, let's see the search results. Funding, we've just kept it a minimum, because we know that's not necessarily a discussion that a lot of social workers have with the patients at this point, but it does allow you to search for concessional beds. And then the physicality of the room. So is it a single, does it have an ensuite? We've also popped smoking in there, because we know there's a fairly polarised view of that amongst providers. And homelessness, or where are we, at risk of homelessness, whereby there's specialist funding, because we know that process with VTAC and appointing guardians and going through the financial means testing is quite a lengthy one, and there are only 17 providers across Australia that have certain particular homelessness funding. So with all of this, of course, comes all the data. And so certainly from the hospital standpoint, it means that these outliers, in terms of those that are the most vulnerable, those that perhaps do have the most complex needs, really do become the most visible for providers, and that they can see them as opportunities to be able to shift their care and shift their offering to that of the catchment. So in any case here, I'll just press search. I haven't selected anything other than Parkville in this case. Maybe a moment. What you'll find here is, just as an example, facilities with vacancies within 10 Ks at Parkville. I think, where are we? I think we counted around about 90 odd facilities within 10 Ks of Parkville for Royal Melbourne. So we have 51 of those. Will show a result that matches just straightforward permanent care. You can search for all facilities that are represented across this portal. They can certainly search by nearest location or newest updates. And I suppose bear in mind, the only way a provider can, or nursing home, or a provider, albeit NDAs, can affect this portal is by having the freshest set of vacancies. So they're updating it on a daily basis, meaning that where there are wide searches, they're searching for Glen Roy, that's the highest, you'll get the largest number of results, so freshness will count in terms of the ordering, or alternatively where their product is becoming more and more relevant to what it is that the hospital is searching for, which we display to them. So in terms of creating a shortlist is literally, as you can see here, this is what a listing looks like. Everything at a residential sort of care level is here. Then the time it was updated, in this case it was 8:57 today. It will show the social worker everything that facility has on offer, whether available or not. It will show if there's certain funding against that, and it'll also allow the provider to put a note there, perhaps if they have something additional to tell that social worker that doesn't fit into the standardised template. They can then view the profile on our public site, which, as Tal mentioned before, is a directory that was built many years ago, but certainly our providers update with their photos where they can talk about lifestyle aspects, etc. And then they can just literally, the social worker will then add whatever suitable facilities are to a shortlist. That then say this shortlist. In the case of Monash, as an example, they are naming it with a UR number, as this is just an administrative tool. It's not an e-health record. And then leave notes internally for each other about this particular patient, which are all encrypted. Put in the ACAS paperwork delegation date, so it starts to track that particular search and keeps it live from that point forward. And then, where are we? And then saves. They can also notify the providers that have been shortlisted to perhaps call them at a certain time. We are extending that notification to providers that have been shortlisted to become a form whereby the social worker can ask a provider to come into the hospital and meet with the patient. So if you have shortlisted 6 providers, you can basically communicate out with them through this particular portal. Once that's been saved, it sits in that social worker's dashboard. They can either download a PDF or send an email, get this directly to the family. This is the 3-minute bit. Might be a moment. Where this is what the family receives, they know which hospital it's from, clearly. When it was created, what the social worker's details are. There's a reference number for the nursing homes or providers when they head to them to go and see the site tour. But the most important thing about this portal is that we have all the contact details up front, because this portal is all about connecting social workers, families and providers as quickly as possible. Or, as I said, they can send it in an email version. This particular search can then be, say in this case, in terms of tracking the journey of care, or say in the case of Monash, if someone started off in Clayton, went to Kingston and then headed off to TCP, and their placement hadn't been resolved, this search could then be handed right through the whole way. And certainly, in terms of being discharged into residential care or wherever it is that the discharge reasons are for, that's where all that data is tracked. So we'll be able to tell you what the average length of stay is for these particular patients by what was searched for, the radius of that catchment, and what their discharge ended up being. So all that data is tracked, and it's certainly tracked in real time. For the social worker, at any given time, we've just created this shortlist, so it won't have a lot in there. They have a large set of care data that says how many days that care search has been open, or that shortlist has been open since paperwork, how many shortlists have been issued to the family or reissued to the family, and most importantly, are those beds still available, and who do I ring to talk to see if the family has been in to see them. And that's pretty much it in a nutshell. Thank you. So certainly from a data perspective, all of that is tracked, and each hospital has their own metrics or their data requirements. As far as providers participating in the portal, it's something we've made accessible to all providers. It's not a commercial relationship to be able to submit your vacancies in real time. We believe that's something that, you know, should hopefully be able to affect the gap. What we can do, sorry, wait me a moment. What we can do is also give them a deeper dive. So if they're opening up a new wing, if they're looking at a new product, if they want to assess where, as a provider, they should be heading, should they be creating more Turkish bariatric smoking offerings? Are they sitting in a glut of dementia secure offerings within that particular suburb? We map that all for them and then track over time, and have been tracking which providers are sort of aligning themselves more. Oh, sorry. Yep. So hopefully over time we'll see an alignment of what providers are offering, and certainly what the catchment needs are and the emerging needs, and whatever may be sort of a placement problem for hospitals, hopefully will be an opportunity for providers to make the product more relevant through this portal. Thank you.
Thank you very much. I think our heads might be spinning a bit after that very speedy, very speedy. Yes, yes. No, I could tell that you were. It was at least 2.5 times. But thank you for that. I appreciate it. Any comments or questions? Yes, there's one here. Thank you.
Oh, hi. I'm Ellen Duffy from Royal Melbourne Hospital. I'm just. Do you have any quality checks for those facilities? Like, you know, is there a way that you could keep ones off that don't have,
yes,
you know,
sanctions,
a good care kind of?
Yeah. Yeah, we have a live sanction search, if you like, monitoring system that our development team has developed. We also, in the back end, and obviously pending what happens with the Royal Commission, will be following suit, but in the back end we are just about to open up a set of filters that nursing homes can voluntarily submit how many RNs they have on staff, how many FTEs, what their qualifications are, what they're doing in the integrated high care dementia space, obviously the accreditation for those particular training methods. We're just coming up with a template. Doing it voluntarily initially hopefully means that obviously the best offerings will be surfaced to the social workers, and then others will follow suit.
And just to add to that too is the development of quality indicators. So health service, aged care services will be encouraged to actually report those, and that should be public knowledge. So if they're doing pretty well, then ideally they come to the top of the list and be much more encouraged. People will be more enthusiastic maybe to go to residential care if they are feel that it's going to be a safe place.
Oh, very much so. And look, you know, Cal and I have been to many hundred meetings where people are doing some really great work in that space, and we're hoping that we can surface it with this portal and work with the outcomes of the Royal Commission and the new standards to be able to certainly give social workers a bit more of a line of sight on the clinical levels of care, and also obviously lifestyle as well.
One more? Yes. You just have to wait for the mic, sorry, because we've got people on the web.
Should have wanted it on.
Thank you very much.
It's John from Eastern Health. Look, I came in a little bit late though. Are all providers in the database? So we've got all, okay, great. No, thank you.
Yeah, absolutely.
One more quick comment there, yes.
Just for, I mean, if we're looking at patient-centred care, if someone's already in a facility but wants to search for another one, or their family wants to, are they able to do that using this kind of? You've got a public face, haven't you?
Yeah, so we've got a consumer site as well, so the public-facing site, so they can absolutely have a look through that. In terms of vacancies, at this particular point, it's not going to be public at this particular point, but we certainly have an aim to surface that.
And to that point, we also have the Northwestern Mental Health team, their basics team, who are very much on site and residential facilities, rehoming, replacing people who perhaps have been, perhaps need rehoming because their behaviours or whatever the case may be might not be suitable for that particular facility.
All right, would you thank with me, join with me in thanking Thank you very much. There you go. Don't go without you.
Oh, bless.
Thank you. Thanks, guys, very much. Yes, so thank you for the questions about quality, because they're exactly the same things that I was thinking, so fantastic. I see John is here. Hi, John. Welcome, John, to come and talk to us about delivering bed-based services in the home. John Ferraro is the Eastern Health Program Director for Acute and Aged Medicine, which includes accountability for 3 emergency departments, as well as acute, subacute, transition care, residential and ambulatory services. And here's something I don't get to say half enough when I'm talking, when I'm introducing people at conferences. John is a trained orthoptist, yay. So please welcome John to come and talk to us about GEM bed-based services in the home.
Thanks very much. Thanks very much, Kathy. We've also got Dr. Simon Groff here as well from Eastern Health. He's our Clinical Director for Coordinated Care, and he's really led this particular initiative. So there will be an opportunity to ask Simon any questions, or myself, and I generally direct all the hard questions to Simon. So thanks for coming along as well, Simon. I'm going to start off just with a patient story. There's some details up there, but Lily was a 110-year-old patient that was at Box Hill Hospital. Lily's not her real name. And she had a fall and was admitted to our subacute ward there at Box Hill Hospital. And she was very unhappy, and clearly, as each of you would appreciate, was at risk. But she was keen to return home, and obviously, and was requesting an early discharge. She was seen by the geriatrician who is no longer at Eastern Health, but he approached Lily and said that Lily is the oldest patient he's ever seen. And Lily, who had a very good sense of humour, responded, "Look, that might be good for you, but it's clearly not good for me." So she was requesting an early discharge. The family were supportive, but also obviously concerned to allow her to go home back to her accommodation. So there were really 2 options, as again, wouldn't surprise you. She could either stay in a inpatient setting, or she could be discharged home, at risk is what we thought. So fortunately, at around about this time, we had initiated our GEM at Home program, which was a bed-based substitution. And Lily fortunately was able to be discharged the following day. She was the first patient that we had in our GEM at Home program back in April 2018. The next day she had an assessment from one of our CNCs, and she received all the GEM at Home intervention, which I'll speak to a little bit later, which was able to support her accommodation at home. So pleasingly, the outcome after 2 weeks, she was very happy, and so was her family. She was healthy, mobile, more independent. No readmissions, and we think we probably avoided at least 2 weeks of bed-based subacute there at Box Hill Hospital. So a really pleasing story for us, and most importantly, really pleasing outcome for Lily and her family. So I'll just give you a little bit of background in terms of how we started GEM at Home, and really the real driver was that there was an unmet clinical need, and I guess Lily's story really highlights that. Prior to GEM at Home, Lily would have remained in hospital for at least 2 weeks, as I said. We had some existing services, but it wasn't complete, and we thought we could do better for our patients and really allow them to go home earlier with a comprehensive suite of services. So we undertook a pilot as part of our winter access strategy, which we opened up 10 beds out in the community and operated those for the period of the winter period, which was for the 4-month period. It also coincided, I guess, with the opening of ICU at Angliss Hospital, which allowed us to operate a hybrid ward, which then allowed us to continue running those 10 beds out in the community. And really, I think that the other driver was, and it's great that Simon's here and his team, but they were really willing to seize the opportunity. I think the enthusiasm that we had from our clinical team, they really wanted this to happen. So as I said, it was really, for me, it was important to assemble the right team, the right leaders. So Simon and his team really drove this initiative through the pilot phase, and it has subsequently continued. We obviously prioritised our work, sought some advice. We did borrow knowledge and resources from others rather than trying to reinvent the wheel. Good communication, and we obviously recruited, seconded, and at times diverted staff to this program because we all felt that this was the right thing to be doing for our patients. And as I said, it's a bed-based substitution model which really replicates GEM in the hospital setting. It's a 7-day-a-week service. As I've listed, the whole range of disciplines are involved. The client and the family, as you would appreciate, are integral in terms of providing the care. And we get referrals from ED, subacute wards and inpatient wards. And it's good to see, I guess, Dan here, our nurse unit manager for ED. I'd be interested to see whether or not any referrals came from you, Dan. And we deliberately had a broad inclusion criteria and a relative exclusion criteria. We're really wanting to encourage the discussions to get patients into this particular program. We established a green light criteria. I won't go through all those, but happy to share them with you. And then there were also other examples where we required medical consultation before acceptance. And again, there's some points there in terms of which patients required medical consultation. Some of our challenges, it's a large catchment at Eastern. Don't know whether many of you have been out in the east, but it's a huge catchment, and for 10 patients that might be scattered throughout the east, it's logistically a challenge for our teams. And I'll get to that a little bit later in terms of what we're planning on doing. But in terms of the zone is from Kew to Mount Waverley, Templestowe, all the way up to Warburton and Cockatoo. So it's a wide catchment area that we have. So we developed various pathways and processes. Again, these things won't surprise you. There's a referral pathway, which I touched on. If in the event the patient deteriorated at home, there was a pathway for them to be readmitted. There was various advertising material that supported the program. We got a really good readmission audit. And we also had some really good collaborations with our hospital in the home program and also Eastern Palliative Care. Most importantly, in terms of the next steps, I think I've skipped a few there. In terms of the outcomes, this started back in, as I said, May 2018. So we've had 250 patient separations, which is about 23 per month. The number of occupied bed days over 3,000. Length of stay around about 13 days. And interestingly, the referral source for me is always surprising. We had 47% so far have come from our acute beds, which again has clearly avoided a subacute admission. And then again, some from subacute in the community as well. A 15% readmission rate, which again, there's ongoing review of those patients that are readmitted. And most pleasingly, we get some great positive patient and family feedback as well around this program. In terms of our next steps, we're just looking at a further expansion of GEM at Home as we finalise our bed plan. I think we need to look closely around our relationship with HITH. There is some duplication between what HITH are doing and what GEM at Home are doing, and also some of our community TCP packages as well. And also looking at, I guess, the interface with PAL Care out in the Eastern region and the role that Eastern Palliative Care play as well. So I just thought next would be good just for Simon, just from a clinician's perspective and who's led the program, just to give an opportunity for Simon just to speak around some of the positives that he's experienced as the clinical lead for this program, and then perhaps just open it up for any discussions or feedback that you want to provide to Simon and I.
Thanks for the opportunity, John. So I'm Simon. I'm a geriatrician by trade and have been at Eastern Health since 2014 and really started off in the GEM at Home old diversion program, and I manage now as a recent clinical director GEM at Home, the transition care program and the consult service at Eastern Health. So I got on board in 2014, and Eastern Health actually had their own much smaller Gem at Home diversion program, I think even a couple of years earlier, where we would primarily receive community referrals from GP and ACAS. And then with the winter access strategy last year, we managed to increase the beds to 20, so 10 community and 10 of the substitution, or what we call daily clients. And we were able to do that with obviously increase in EFT and funding. And then and they were kind of operating as two separate systems up until about January this year, and they've really been combined quite nicely. So, because for the referrer, it doesn't really matter where they refer to. We just wanted them to refer to Gem at Home. So I've actually got 20 clients now under the program, which is great. It's really exciting. The clients love it. They don't want to be in hospital. Clients, carers, they want to be treated in their own home. We see a combination of complex patients that would otherwise be in a bed-based location, and as a geriatrician I'm able also to look at the acute stuff, but look at the geriatric type syndromes that are a bit more subacute, the cognitive impairment, the continence, the falls, all the sexy stuff that us geriatricians do. We work very much interdisciplinary as well, and not all of the clients who are admitted to our program have to be seen by every single discipline, similar to how a GEM bed-based unit works. And I've kind of developed, you go to people's homes, I've kind of developed a bit of a cup of tea test, whereas in the first minute or so, you kind of know whether you accept a cup of tea or not based on cleanliness, location, all that type of stuff. But no, really, in seriousness, I think it's given particularly some of our junior allied health a real good insight into community services, because working solely in the hospitals, you tend to be much more risk adverse, and by going to communities, walking around, seeing how people really live in the community, if these people did come to hospital, people would be questioning their ability to actually get back home, and there'd be nursing home talk and all that type of stuff. But getting to the community, seeing how they live, it's not how you or I might live, but it's worked for them for 30, 40, 50 years. And certainly I'd be keen to get more and more of our allied health, nursing, even our medical staff through this program. We're busy, as John said, with a very quick length of stay. I think last couple of weeks, out of our 20 patients, in 1 week, we had a turnover of about 18 or 19 in a week. We talked about readmissions. There's a rate of about 15%, and we look at that in a bit of detail as per the ROVE tool, the Review of Outcomes, Variations and Effectiveness of Care, and it's really mainly patient factors contributing to the readmission rather than any system issues, and they are complex patients, so that's not terribly surprising. And really the main issue for the clinicians is the increase in travel and distance. You know, that can really limit how often and how far we can see our clients. In terms of the green light criteria that John briefly mentioned, we want to make it open to people, and we're really a no wrong policy. So usually 99% out of 100, we will accept these patients, no matter how simple or complex they are, as long as there's a few different disciplines. They're kind of not better managed by, let's say, just a pure geriatric clinic or to post-acute care or something like that. My wish list, I'm glad to see that hopefully we will be expanding. I'd love to get some junior medical staff on board, because I think that's a great training opportunity for them. A lot of our junior staff are really much more bed-based, and we're based at Wantirna Health, office there, potentially getting, if we're going to expand numbers, to restrict the driving to get another satellite site. You saw how big our catchment area is. A satellite site towards the Healesville, the outer east suburbs would be great from our point of view. Good. Happy to open up to questions.
Thank you, gentlemen. We have 1, 2, 3. All right, we'll start with those and see how we go. So just hands up again, nice and high.
Who was first?
No, behind you, Andre. You'll just have to hold your horses there, Andre.
Hi. With your large catchment and with the role that you play, what, if any, telehealth involvement do you have?
At the moment, there isn't any telehealth, but I think as the service expands, That's the opportunity that I think it presents. We are looking at some telehealth with our hospital in the home program, so there might be some opportunities there for some, I guess, cross-fertilisation between the program. But at the moment, there isn't any. But I think it's a really good point, because it is a large. It's 2,800 square kilometres out there in the east, so it is a large catchment for us.
Thanks for the talk. That was really insightful. I picked up on the point that Simon made. I think it's a really good reflection. Often we reflect about how successful it was in terms of outcomes, but the reflection around the learnings for our medical teams or for our clinicians more broadly, that's a really interesting one. And I've heard about this model before and not really considered that. Is that something that you're going to deliberately follow now in terms of making sure that our allied health and our medical teams do have an opportunity to rotate through there, or is something just a bit more organic that you've noticed so far?
Yeah, thanks for that. I'd certainly, there's nothing in stone at the moment, but I think it's a really good, as I was mentioning, a really good opportunity for us all. Even seasoned geriatricians who have joined the program who have only done bed-based services. Just I think their breadth of experience and knowledge has just grown exponentially over the the short period of time they've been working with the service. But and we're quite lucky to have a lot of very senior allied health leads teaming up with some of the junior staff that and we're always a phone call away if there's any hairy situations, not sure what to do. But yeah, it's a good point.
I think the other challenge is just the size. It's only 20 beds at the moment, so we probably, in terms of getting those rotations, we probably need to get a bigger critical mass so we can get some of those rotations through. But the principle is there, and as Simon said, I think it's a valuable experience for all our staff. So we're not there yet, though, but the intent is to grow it even further. And again, as I said, from a patient's experience, the feedback has been fantastic. I could spend the next couple of hours talking about some of the feedback that we've received from patients and their families. And for me, that's what really gets me out of bed in the morning, to actually hear that feedback. And we are actually heading along the right, the right pathway from an Eastern Health perspective.
You're welcome to come up here and ask your question.
We can repeat.
Hello. Sorry. So again, sorry for those here a fair bit today. So Mel Reid from Alfred Health. We also run a GEM at Home program, and we're now calling it Better at Home as well, because we've broadened that to rehab. And like you, I think we're finding it exceptionally rewarding and a great way to reduce the risk aversion of our team by having exposure in the community. So it's great to see more and more people doing this work. The question I've got is about identifying, because these are bed substituted models, what is the difference in capacity and capability in the home versus the hospital? And how do we start to that gap so that patients, just to understand the difference. So I'm just wanting to throw to you around any thoughts that you've had or particular investments you're looking to make to actually deliver truly bed substituted care. And it's a hard question. That's why I'm asking it.
Which requires a brief answer today.
Get all the hard questions.
Yeah, thanks for that. Listen, I don't have an answer off the top of my head for that, but I suppose in our bed substitution, we're really trying to identify patients, clients who don't need to be there, who may only need one or two disciplines, not every day, don't want to be there, and focusing on them to get them out of the hospital system to improve flow through the whole of Eastern Health. But what we've done really well is those kind of clients and families that you're not quite sure whether they're actually going to make it back home. And previously you might have organised the community transition care program. There's a wait sometimes for that. GEM at Home, we usually accept the referral on the same day, and our bed availability, it'd be only a day or two before we could get them in, and then we could liaise very closely with the transition care program if indeed they are successful at home. We've got good process with our access units, actually get them back into hospital if things fall apart. And I think that's where we can really value add. And the old trial of care on the ward, we're actually doing a trial of care at home, exactly. But no, Alfred has been leading the way as well. You guys have done great.
It's probably worth acknowledging that I did visit the Alfred prior to commencing this program, so just want to acknowledge Alfred. Should have put that in the slides, so I do apologise, but well done. And I think that's a challenge for us in the future in terms of what patients we can move into Gem and Home, though. And I think, as Simon said, we don't know yet, though. I think we've just been able to stabilise the program, get the 20 beds out there. I think the next step is for Simon and I and others to decide, well, can we actually push the envelope a little bit further? Are there other cohorts of patients that are sitting on our wards that could potentially be seen at home, though? So I think that's the challenge for us. But it's a great program.
One more. I think we've got time for one more quick one. Thanks, Steve. You're working off that lunch.
Ellen Duffy, Royal Melbourne Hospital. I was just wondering, are GPs a big part of it? Like, are you utilising the GPs to kind of keep people out of the hospital? So instead of sending them in an ambulance to get treated for a UTI or something, are they coming to you for advice or support, or?
So so Simon's giving me the hard question now as well, just to even it up. So there's probably, specifically with the Gem and Home program, as Simon touched on, there is that diversion 10 beds. So they're the patients that would be referred from the community to actually divert a particular admission. So that's still working, and we joined the two teams together in January. There's probably some broader work that we're doing, particularly within ED and within AV and with our Resi and Reach program as well, to avoid some admissions. But we've just started doing that work at the moment. Is there anything you want to add?
I suppose with working with the GPs while they're admitted to the program, it's a little bit complex because of the funding. So we liaise very closely with them, and rather than duplicating tests or whatever, we'll see what's been done in the past. But no, they're very much on board with the program, and you need to have close contacts with them. Yeah.
All right. Thank you very much, and join with me in thanking John. Thanks very much. Nice to hear, huh? Won't it be interesting? Of course, the people who are going to live till 132 in the room will see it. Some of us won't. But won't it be interesting in 50 years to see where the hospital of today ends up, and if it indeed even exists in anything like its current form? Very much on the home stretch now, and it is my great pleasure to introduce Jackie Plunkett, who's going to talk to us about timely access to specialist care in a Resi aged care facility, which I'm rather keen to hear about. Jackie's the Director of Health Innovation and Telehealth for the Loddon Mallee Rural Health Alliance and the President of the Australasian Telehealth Society. Before this, she was the Director of e-Health Services for the Northern Territory Department of Health, and has over 22 years experience in the IT industry. Please welcome Jackie.
Just because I've worked in the IT industry does not make me an IT expert. And please don't beat me up, I'm not the clinician. In actual fact, I very loosely say I'm in the IT world. I'm actually sit more in the business world. That's my actual background. However, I also send my apologies. Associate Professor Mark Budge would have liked to have been here, who's the geriatrician that supports our Geri Connect program. Some of you may have heard that is supported under Better Care Victoria. He couldn't be here, so he sends his apologies. In the beginning, okay. When I first arrived around 5 years ago, what we were trying to identify for our regional health services is what is the clinical gap that regional health services have access in regarding access to care. Now, public health facilities in our catchment, 80% of our beds are aged care beds, which is, 70% of our beds are aged care beds, which equates in the public health setting to about 800 beds. So it's no surprise when I asked them what their top three was. Number one across all of them, which isn't listed because they actually all consistently said it as their number one, is access to ACAS assessments. They were taking quite a while, and as was alluded to with the Daily Connect program, that wait time was a big burden on regional hospitals. Also, access to geriatrician support or geriatrician services in residential aged care and acute was a major issue. So I had a really clear objective of what my low-hanging fruit was. So of those 800 beds, approximately 50% of those had queried cognitive impairment. Come on, better. Only 4% had been seen by a geriatrician in the preceding 4 years. So our aim was to target, and is to target 80% of those patients to have a comprehensive geriatric assessment, and 2/3 of those to have follow-up consultations. So part of the reason for that backlog and for that disparity in access to services is we had a travelling geriatrician who was 0.5 FTE, travelling around to all of these health services. He loved his drive, he was loved by the communities, but he was pretty flat out when he got there. He was either doing ACAS assessments, and in the opportune time, he was able to go and see Mary in the aged care facility who's getting quite unwell or having some issues around cognitive impairment. Again, not the clinician, so if I say things wrong, correct me, I'm not precious about it. So, that was a real jewel in the crown. That actually really made it happen. Some of these people also have some of the people from the community coming through as well, and they're able to suggest gently to the GP that perhaps Mary needs a referral into their geriatrician. We also provided technical training on the technology. We had a very old technology layer. We actually replaced it with a new, very easy to use interface. We made sure that we documented all of our processes so that everyone understood how a GeriConnect clinic would run, and communications so that the nursing staff could actually liaise with the families when discussing this as an option for their family member. So as you can see down the bottom, very high overview, referrals made, we triage it to ensure that it can be a telehealth consultation. There's a pre-clinic process, so the referral is sent through. It actually already has a screening process in it, so they can actually make a large percentage of their assessment based off of that form. They have the telehealth service and then the post-consult follow-up. Across the service, we've seen, we've had 1,000 consultations as of 12th of March. We've seen 600 patients, so 565 public and 32 private patients. You'll notice on here that some of the health services have seen up to 200% of their patients. The reason that is because they capture it as an opportunity for respite care. So a lot of the people who come in for respite care are probably some of those people that potentially would be admitted into hospital, and are probably more of the chronic people who have a higher acuity need. That's why the family needs a bit of a break, or that's why they need a bit of a break. So the aged care facility is using that as an opportunity to grab them. The smaller the aged care facility, the more likely they are to use the service. The larger they are, the less engaged they are. It's quite interesting. And the GPs initially were a bit, why do we need this? I've been managing aged care patients for 20 years and I don't need a geriatrician. Thank you very much. Our argument back was, it's time. Do you have an hour to spend with each of those patients to actually comprehensively go through each of their requirements? No, they're not funded to do it that way. A geriatrician is. So therefore, here's a trusted resource that can actually spend the time to do that on your behalf and can write the recommendations back to you for a care plan. GP is still in charge of the plan of care. So the impact, we've had 89% have had recommendations to reduce or change their medications. 29% have had allied health referrals. Another 29% have asked for further investigations and behavioural management strategies to 21%. But even bigger, our ACAS assessments, there was a minimum of 8 days. It's now to 24 hours. So we can do ACAS assessments within a 24-hour period if it's clinically appropriate. So timeliness, it would take them that 4% if they didn't have the geriatrician come out to visit them. If they made an appointment, it would take 2 to 3 months for them to see the geriatrician in Bendigo, so they would actually have to come and travel. That's now down to a maximum of 2 weeks. So as soon as we get the referral, we generally schedule them for the following week. Some aged care facilities actually have regular spots that they're actually rotating their residents through the service. So 4% up to 30% across the region. Now, if you break that down, our original catchment wasn't 2,000 beds. Our original catchment was 800 beds. Of those 800 beds, if you took out our larger services of Echuca and Swan Hill, of the smaller facilities, we've already reached 63% of the people in those smaller facilities, which is pretty good. And as I said before, our ACAS assessments are down, in-hospital ACAS assessments are now down to 24 hours. So has it made a difference? We like to think it has. Polypharmacy is being reduced. Better engagement strategies are put into place. We're speaking to our GPs. Our GPs love it. Our nursing staff love it. If we have regional meetings, our nursing staff heckle us. We love Geri Connect. If we took it away from them, it would be a shame. Part of the reason we were able to establish this service is we were able to get additional clinical resource. How? The business model stood up under an MBS business model. So we actually were able to fund it. So what's the acceptance like? Well, what's the acceptance like? I think they're pretty happy. Indications are that they're pretty happy with the service. And like I said, if we went to pull it away now, it would really cripple our region. We're also being asked by members of other regions whether they can actually have the service, and we'd actually like to work with that region to let them replicate the model. If they don't have capacity to replicate it, we have a flexible environment that we can actually stretch up if we need to. So the critical success factors, number one was there are 4 key pillars you have to have whenever you're establishing any of these telehealth services. 1 is, does it clinically make sense? 2 is, do you have the workforce to support it? 3 is the technology layer, and 4, which is really, let's face it, the real crux of it, do we have the financial sustainability to do it? And we had those 4 pillars to support the program. We also had local champions, which I mentioned earlier, which was the nurse unit managers who said they wanted the service in the first place. Well, you've got it, now use it. Management was supportive because, again, they were the ones coming to us asking for the service. We've got continual engagement with the sites. So we have a clinical nurse coordinator who plays an educational role as well to say, these are the types of people, this is the types of behaviour you should be looking for to refer in for an assessment. Good technical infrastructure, sustainable funding, patience and a long haul vision. It took a while, but now it's growing from strength to strength. It really is a success. we'd like to expand it into further clinical areas, so remote patient monitoring, and expand it potentially across Victoria. So last word from the Don, I'll leave it to you.
Thanks, Jackie, very much. Lots of great good news stories, huh? Fantastic work. Any comments, questions?
Either I answered all of them or...
I don't think it's not that they're interested. Not at all. Interesting, isn't it, that when you meet a need, it really does help make things happen. Sometimes I think we try and make things happen and the need's just not there or not recognised, or we haven't made the case enough. I think linking it to the business model is brilliant and always a good lever. And I like the particular way you manage the GPs. Well, I know you want to be in charge and you can still be in charge, but you can't spend an hour with these people. Yeah, that's right. So it's absolutely fantastic. Yeah. So I thought that was really, really clever. Yes. All right.
It's Keith from Bowen Health. I'm just wondering whether you have any remote patient monitoring as part of the sort of telehealth service as well.
That's our next layer. In actual fact, the remote patient monitoring program that we're looking to implement is 4 pillars. So it is the Commonwealth Home Support Package patients, it's hospital in the home, it's heart patient, and it's HAC PYC patients as well. So, and it will also include some GEM at home patients as part of that as well.
For you, Jackie. Bilby, thank you very much. Thanks, Jackie.
Sorry.
Oh, I'm sorry.
Yeah, no, it was more just a comment. Sorry, Elise from Barwon Health, that we actually implemented telehealth in the outpatient specialist clinic and elective surgery department with our pre-admission clinic space, because with Barwon Health our region is quite large. So I think it's just also out there that there's not that is an impact of bed-based services, but there's definitely benefit to the patient, the GP, anaesthetist and surgeon collaborative relationship in
cardiac care. Please welcome Harry to talk to us about Beyond the Walls.
Anxious wait. Great, thanks a lot. So it's just the arrows up and down. Yep. Look, thank you for the opportunity, and also thank you for sticking to the end. I think it's always hard to be the last speaker. Never know how many people are going to be left in the room, but I'm glad I didn't have to lock the doors to keep you in here. And I'll figure this out. I want to start by acknowledging the traditional owners of the land on which we are meeting today and pay my respects to their elders, past, present and emerging. Just as a bit of a starting point, look, this is the overview of what I'm going to present, but it'll unfold as I go. But I just wanted to know who in the room has had a discussion with their PHN or understands what a primary health network is, so I know where to pitch things. A couple of heads shaking. Yep, great. If you haven't yet, you're missing out, so you need to go and hunt them down. But I can certainly take you through a bit of detail about who we are and what we do. PHNs are organisations that I guess are maturing as we go. So they've been around through a government initiative since 2015. Oh, sorry, that's not working on that screen. That's right. That's okay. You'll see the slide in just a second. I don't want to do interpretive dance to these slides. I don't think you want that. So the primary health networks were a Commonwealth government-funded initiative. You might have heard of Medicare Locals beforehand. Change of government, change of vision for what those agencies would do. Primary health networks came about. There we go. Primary health networks came about really through reorganising some of the boundaries and amalgamating those Medicare locals. And we now have 31 across Australia, 6 in Victoria, 3 rural, 3 metro. Our funding really comes in numerous forms. We have an operational budget, which means that that's what we use to fund our own staffing and overheads, etc. But what's of main interest to people outside of the PHN is the money that we're given from the Commonwealth to look at commissioning services. A lot of services that are essentially patient-based, but also services that assist around innovation, transformation, and piloting new ideas. Some of those are quite flexible and based on need. Others are specific within program areas such as after hours and some of those named on that slide. Look, we're certainly aligned from the point of view of the interests of the acute health system in the sense of timely access, timely care, right place, right time, but also reducing unnecessary presentations and admissions to hospital. So our interests are shared from that perspective. Huge boundaries, talking about Eastern Melbourne PHN, we have 1.5 million people who are in our catchment, all the way from the city of Burundara right out to Whittlesea, Healesville. So PHNs have become larger and larger, and that's been a struggle for us, trying to do more with less. But it makes a lot of sense around population-based and area-based planning and service delivery. Each of the PHNs are required to produce at this stage an annual needs assessment. That's just an example of some of the insights that we gain from the needs assessment we produce. We also produce an annual work plan. So again, I'd encourage you to look at what region your hospital sits within and have a look at that PHN website. And what you will find there is, please don't duplicate, particularly the needs assessment. We're funded to do that, and we do a pretty good job at understanding the needs of the community and some of those areas, from prevention right through to palliative care. So encourage you to have a look, but also the annual work plan about where your strategic planning and operational interests fit with your PHN's interest. Hopefully you've been involved in some of that workup of that annual plan as well. What's the role and interest of the PHN? We see ourselves as an integrator, an innovator, a commissioner of services, really interested in system redesign, a partner in services that are delivered within that community setting, but also planning for now and future healthcare needs. Personally, from an Eastern Melbourne PHN perspective, we have a bit of an ambitious transformation agenda. That transformation agenda is really trying to ask ourselves that question about how do you get that fundamental change that we've all been looking for, particularly around change that's going to be sustainable and scalable. What I mean by that is, how do we really understand what enhanced primary care looks like and the levers that will get us there? What does real service integration look like, and those sorts of things? So a bit more ambitious, I guess, than doing more of the same, which really hasn't had the kind of the structural change we've wanted to see. I thought it was worth mentioning this about a growing interest for primary health networks, but also for community services around this concept of stepped care models and risk stratification, so that what we've known over time is that a lot of the acute service models have been concentrating on that top end of the pyramid. So these are people who have been identified through HARP programs and health links and those sort of opportunities. What we're learning is that certainly a portion of the population that are using most of the services, there's no doubt about that, particularly the acute services. But what we feel is an opportunity from a community acute interface is that rising risk kind of patient cohort. Really thinking about how do we target people earlier with interventions that may not be at that same level of intensity, but can actually make a difference to them being the hospital presenters of the future. And then, of course, the majority of the population is still very much low risk prevention-based kind of interventions. But so how we look at that and how we then match services towards risk is becoming of far greater interest to governments and PHNs and the people that we work with. The other thing I wanted to mention is that concept of collaboration. We've been really fortunate at the Eastern Melbourne PHN to have a collaboration in our north and our east. And what we've managed to do is bring together the regional offices of the Department of Health and Human Services, the hospitals in our region, and our community health services and general practice. We're actually having conversations as a system, a care system, about how we transform and transform the way that we work together to make a difference. And this is really showing some great promise. And the Better Health North East Melbourne Collaborative has identified frail older people and children with developmental delay as key populations of interest to look at how we reduce readmission to hospitals and reduce waiting lists to specialist care. So hopefully in the future we'll see some great outcomes of that. But again, I just want to encourage you to think about how you collaborate and how you network with community programs within your area. They're very willing to do that. And we've got CEO level commitment on these collaboratives, which is, again, fantastic at that senior level decision making. You know, what's the value of a PHN? Sometimes we see ourselves as that tugboat. Sometimes we see ourselves as that flea on the elephant. You know, when I talked about the money that we've got, it's a small amount of money, but the way that we use it is hopefully to allow ideas that have been sort of sitting around to get some initial seed money to start happening. And I'll give you some examples of what that's looked like for us. And again, these are replicated across the PHN world. One thing that I wanted to really highlight is the fact that we really try and keep the patient voice central to what we do. There's been a tendency, and I think we all do this, to go out and ask patients that question: what are you frustrated by? What would you like to see happen differently? I think we know what that looks like. And we've really captured this as a bit of a guiding principle to the work that we do. You know, it's clear that, and this is patients who have chronic complex needs, feeling overwhelmed, confused and frustrated, frightened and distressed, feeling that the emergency departments are the only option, worn out about the work they have to do to get the care that they need. You know, these are very unwell people feeling like they have to fight for the care that they want. Not a great indictment about how we provide services and how patient-focused they are, even though we use that language a lot. So we've got a lot of work to do from this baseline to try and change that client perspective and their experience of care. I think there is that. Now, I'm talking generally. We certainly know that there are some cultural aspects to people feeling like the ED is a one-stop free shop, and there is a perception change that we need to encourage around some of that. But generally speaking, people have a preference for care that looks like this. Yep. The struggle is that they don't feel that they can access care that looks like this. Yep. Examples of how we're making a difference. I just wanted to highlight a couple. This is some work we've done around diverting simple fractures from a pathway that looks at outpatient services into a pathway that looks at general practice. So we had an idea that said if we worked with hospitals and the orthopaedic departments within hospitals and created a bit of a network of general practice who was willing to see simple, and then we put the program within 3 hospitals. Bit of a sense of what that pathway looked like. Essentially, ED providing the first aid and patients given the option about being managed within their general practice setting rather than the orthopaedic outpatient setting. And this is what happened over time. So all hospitals through this mechanism were able to significantly divert the number of people who would traditionally be managed in an outpatient environment back out into the primary care environment. The patient acceptability of this program was 95% plus. So that sense of what would you prefer to do, 95% of people signed up to go back to their GP. Very acceptable to patients, very practical about how this works. This is just some data from the Northern Hospital around what changed over time. This is a 12-month implementation, 12-month project, about a 6 to 8 month implementation. You can see significant differences in diversion rates for these fractures that would normally be sort of seen within an orthopaedic environment. The other thing that I wanted to just touch base on, and speaking about telehealth, was really about timely access to after-hours care. The PHNs get a significant bucket of money to try and boost after-hours services. We chose to try and look at innovative approaches for ours, and we commissioned a telehealth model for the after-hours program, looking at residents who were more likely to present to ED departments in the after-hours space, and they're listed there. The point of difference around the My Emergency Doctor, so you can download the app. So it's a fee-for-service model, so anyone can access it if they're willing to pay at the moment. But we as a PHN have commissioned them as a service provider in the after-hours space, so we essentially are paying for that access for people in our community. It's available 24/7. It's app-based so that you can have the face-to-face kind of FaceTime consult, but it's also available as a telehealth option. The point of difference here is that it's actually staffed by emergency physicians. So these are the physicians that people would see if they were turning up to an emergency department, and a capacity to be faxing scripts or communicating scripts to the pharmacy, ordering pathology and imaging results, and also communicating that information back to the GP around what's happened in that after-hours program. Speaking of the culture change within the community, we had to do a lot of that engagement to get people to understand this service was available as an alternative to presenting in the ED department. We've seen a steady increase in the number of people who are accessing the services, and these are some of the early results. What's worthy of noting here is that only of all those people who called in, only 18% of those cases couldn't be managed, within that in situ home environment. That had to be either have an ambulance called or referred to the emergency department. Stronger results than your traditional nurse on call models or your, doctor on the phone kind of models. 74% of those respondents who received the service indicated that if they hadn't, that their option would have been to turn up to an emergency department or call 000. So, and these are the sort of conditions. The other thing to note is those populations that we were targeting are actually the ones who are using the service, particularly families with young children who want to be reassured about what's going on and whether they should be escalating this as an emergency and having that reassurance that it can wait. Talking about the economics of this, they're pretty stark. I mean, I think that's because we know emergency presentations and hospital admissions are relatively expensive. The other option around aspect of telehealth, it is so readily accessible and it's very scalable. So, that access issue around these sorts of programs is far less than a physical location or confined to a particular workforce. Opportunities in learnings. I think these are really important aspects that we've learnt along the way around timely care and innovation, that patients are actually open to alternative models and find them acceptable when they improve timeliness and access. So it's not a hard sell to patients, and they that build and they will come definitely works. We've heard it many times today around capitalising on technology. I think health has been a slow adopter of technology for a very long time, and we really need to catch up. We need to do a little bit of myth busting around the general practice is not capable or not interested. Through our fracture management program, we were able to recruit over 30 general practices. In phase 2, we are oversubscribed to the number of general practices who are interested. They're interested in developing stronger relationships with specialist care. They were willing to bulk bill patients, even though they weren't a traditionally bulk billing clinic. Whole range of things that they would do to engage more in this sort of space. You can't underestimate that need for trusted relationships in that clinical space. Some of the things that we heard early on was general practice is not capable of doing this. Not true. The other thing that we hear a lot of is it's just easier for us to continue the pathway of care that we're doing and to get people through the emergency department. It takes too much time to divert people. I think you need to break down those barriers, otherwise it's really difficult. PHNs can be a valuable partner. I think these are the roadblocks, ones that you've probably already identified. Perseverance pays off. I think the other thing to really note, which we constantly suffer from, which is that clinicians and hospitals and people are generally good at telling you the 10% it won't work for and finding those case studies, but we forget about the 90% of people that it will work for and the difference it can make. Thank you.
Thanks, Harry. That was actually a pretty fine old summary of the last couple of days. Yes. So I'm very, very impressed. Means I don't have to say anything now. But you're right. Leverage where you can. Consumers are open to alternatives. Sometimes we say, oh no, the consumer wouldn't like that, and try and make that decision for them. People like GPs, if you present the right case, no one's immovable. Yep. Let's use technology a bit more smartly, perhaps, than we have. So it is a great summary. We have time for one quick question or comment. from Harry? It's a big ask, of course, this time of the day. And we did have PHN on the panel, of course. So,
Yes, Robin,
we did
I
have
see
the
that
opportunity.
was
That's right. So we did have the opportunity to talk PHN a little bit with Robin, which was fantastic. All right. Well, Andre, yep.
Just because I can. Hi. Thanks, Harry. I'm just interested in the future of PHNs. We've gone from Medicare Local. I mean, do you feel that as an organisation that it's going to be around for a while? Because I think we need some of that sort of security and sustainability. Yeah.
I think, has the election been called? 18th of May. Look, the indications we have, because we obviously speak to both sides of politics, is that the agenda from a Labor government in a primary care space is not going to be immediately, let's change everything. I think that their PHNs have been showing their value, particularly around some of the early mental health AOD reforms that the Commonwealth wanted to see. So the indication is that there will be maybe some tweaking, but not, fundamental reforming of what's there. The other thing that's been happening with PHNs from the department's perspective, because the department's also maturing within that policy space, is that we're talking about 3-year funding envelopes and work plans and needs assessments. So, and that's actually starting to take place now. So all of the signs are really positive. I guess if you're a betting man, would we get a change in government? Probably. But we're reasonably confident that it'll be business as usual for us. So, yeah.
Join with me in thanking Harry. Harry, don't forget your building.
Oh, yes. Thank you very much. Thank you.
All right, take 30 seconds and jot down one thing that you think you can do, change, influence from the last 2 days. 30 seconds, jot something down. One thing you'll go back and do. Because you can sit here for 2 days and that's all fine and have a nice lunch. But if everyone does one thing, just one thing, however big or small, that's a lot of momentum around the state. Even if it's just having a conversation with your boss, not just, sometimes that can be a very difficult thing to make happen, right through to, yeah, let's chuck something out and completely redo it. Because that's how we make change. All right. It is, as much as it was my pleasure to greet you yesterday morning, it is my pleasure to farewell you. I really wanted to say thank you so much. Thanks for being here, guys. Good on you. I hope that you feel it's worth your while. I just think the couple of days from my perspective have just been so interesting and useful and full of great content. No filler that I could see. I have appreciated very much your punctuality because you've made my job particularly easy. And that's the speakers and the participants. I really appreciate that. And also, as I said, the speakers and the participants, all of you putting up with the data projector, which is giving up the ghost as we speak, I think. I wanted to, I guess, finish on the note that really when people get excited about something, the rest is just the how, So let's focus on getting people excited about the things we need them to get excited about to improve the timeliness of care. We've got all the solutions we need. We've got tons of solutions. If we can just get people excited about wanting to, then we can take us the right solution and make it happen. So that's obviously, to me, it's a really central lesson from the last couple of days. I think that we owe a great debt of thanks to Marie Roberts and her team. They've done a fantastic job, so please join with me in thanking them. As you know, it is no mean feat to put a couple of days like this together if anyone's ever tried it. You can kind of make it look easy by being well organised, but there's a hell of a lot of work that goes on behind the scenes. And my particular thanks to the microphone operators who did a sterling job. Norman Swan would be proud of you, and some of you will know what I mean by that. Norman's very particular about his microphone technique. Taught me everything I know. So you did a fantastic job. Thank you so much. And I'm going to hand over to Marie now, but thank you for making my job very easy. And, you know, go get them, people. That's what we need you to do, and that's what our consumers need you to do. Thanks very much.
And I won't keep people much longer. Thanks to all who participated on the webinar, as well as those who stayed the distance today. My particular thanks to Kathy, who facilitated. I think she's done a fantastic job, so big hand for her. And also my team is really just Deb. And anyone else that Deb and I could rope in. But thanks to the people who were volunteered to help us today, but Deb's done an amazing job as well, and probably did more to organise this conference than I did, and certainly kept the the IT and all the logistics on track. And Brett, our AV person at the back, has done a wonderful job as well in difficult circumstances, as it turned out. So I just wanted to say a couple of things. First, recycle your name badges as you go out. There's a box on the table. Please do that, and we'll take care of them. There is an evaluation, as we talked about, I think earlier. SurveyMonkey will come out to you. It'll be very easy to complete, so you don't have to sit here at the end of the conference and fill out a 2-page form. So we hope you're very appreciative of that. The feedback on the tool that we got is just gold. We've been looking at it and it's just fantastic. Thank you for that. I got all that yesterday, and Deb and I will go back and synthesize that and work out what our next steps are in terms of the development of that tool. I think the other thing we might do is come back to you in a few months' time and see if you've been able to reflect on any of the learnings from the conference. Again, probably just electronically, just to touch in and see if there's any suggestions or any light bulb moments or insights that you've got to feed back to us, because one of the things that we really wanted to get out, and we have absolutely got out of this conference in spades, is your feedback and your participation. So I'd like to thank everyone in the audience for coming as well, and safe driving on the way home. Thanks.